Pratik, sorry.
Bhaskar Pal.
No, and Meera Agnotri madam as well. So we'll directly, anybody else has joined from, I'll ask Lakshmi Shrikande madam to speak a few words. And who else has joined? Parag or anyone? Sir, Sarita.
Even you can ask me, Lakshmi and Pratik.
Yeah, I will be asking you, Pratik sir, Pratik and Lakshmi madam, definitely. मैं तो सोच और कोई है कि नहीं?
So it's 4 o'clock exactly. Let's get started.
Okay.
Shreya, recording.
Yes, sir, you can start.
So good evening, everyone, and a warm welcome from ICOG on this masterclass today on ultrasound and Ob-Gyn. So as everybody says, and we know now that ultrasound has become the stethoscope of modern obstetrics. We know, though of course clinical judgment is the main key, ultrasound is the backbone. And today we are going to take you through all the various aspects of ultrasound and how it can guide us through the pregnancy and, triage the fetuses, whether they are low risk and high risk. We have a very interesting scientific lineup for us, covering all the 3 trimesters of pregnancy by very eminent stalwarts in the field of fetal medicine, both in first trimester, second and the third trimester, and with gynae ultrasound as well, covering follicular monitoring and common therapeutic or diagnostic procedures done in ultrasound. So without any further ado, I would like to invite our esteemed chairperson of ICOG for the year 2026, Dr. Sheila Mane, to say a few words and bless us for this conference.
Yeah.
For this webinar, sorry.
Thank you, Sita. As all of us, we know that ultrasound, as Sita mentioned, is our right hand. Obstetrician and gynecologists cannot work without ultrasound, and updating our knowledge is equally important. So I thank Dr. Sita, Dr. Chinmay, and Dr. Kanchan Prasad as conveners for structuring this program. And Dr. Sita has already mentioned about the topics which are covered in this. And I'm sure that today's masterclass, many people are going to join and they will definitely benefit from this. So without taking much time, I wish all the best for today's masterclass. Thank you.
Thank you, Sheila Madam, for your kind words and always being so encouraging and very proactive in all the activities they've been doing this year. Of course, a big thanks to our FOGSI president, Dr. Bhaskar Pal, who has conveyed his regrets for joining this webinar, this masterclass. And may I ask Dr. Lakshmi Shrikande Madam, our past chairperson of ICOG, who has done immense work herself, and to give her words of wisdom for this masterclass. All yours, ma'am.
Thank you. Thank you, Sita. It really gives me immense pleasure to be part of this masterclass on ultrasound. And as past chair, I really feel proud to see such high quality academic programs being conducted by ICOG, which empower our members with much needed knowledge and skills. I congratulate the chairpersons, the office bearer, conveners, and all the faculties for having this masterclass, because as Dr. Sheila said, ultrasound is our, we all have forgotten post speculum and PV examination. We directly start doing TVS. So it is our right hand or whatever, but it is the ultimate when it comes to our OBGYN practice. And I wish all the success to this webinar, and thank you for having me here.
Thank you, madam. Thank you for your words of encouragement again, as always, and always being there to guide us and support us. Thank you. We now invite Dr. Pratik Dambe, the Dynamic Secretary of ICOG 2026, to say a few words and about this masterclass and about the activities in ICOG. Thank you.
So thank you very much to the conveners, Dr. Sita Pal, Dr. Chinmay Ratha, and Dr. Kanchan Prasad, all of whom are very active GCMs, and they've also served FOGSI in other capacities as well as committee chairpersons, both Dr. Sita as well as Dr. Chinmay. The ICOG masterclasses are actually a very focused bolus dose of the most updated knowledge that you can have in the subject. In fact, I feel it's a shame that we do this only once in a month. We should be doing it more frequently because there's huge demand and there's more and more new advances that are coming out, which ordinary OBGYNs may not always be aware. 30 years back, when I handled a transvaginal probe, I'm very proud to say that all I could see was a snowstorm on the screen. Fast forward to today in 2026, we have such machines which have such superior resolving power that truly it reflects that what the mind does not know, the eye does not see. It has gone beyond our capacity for understanding and interpreting. Therefore, it's important for all of us in routine practice to understand these technologies, harness them, use them to our advantage, and ultimately, this should reflect in the advice that we give our patients, the timely counseling after the detection of issues. So, without further ado, I will hand you back to the conveners. Wish you all the very best and keep rocking.
Thank you. Thank you, Dr. Pratik, for all your words. And we move on to the session. We have our chief guest, Dr. Meera Agnihotri, who will join as soon as she's free. So whenever she joins, we'll welcome her. But in the meantime, we'll start off with our scientific sessions. So for the first session, I'll be taking it, and the further two sessions will be taken by my other two co-conveners, Dr. Chinmay Ratha and Dr. Kanchan Prasad, and thank you for that. Our first session is being chaired by our own GC members, Dr. Deepa Gupta, who is a governing council member, president-elect of IMA East Delhi. Welcome, Dr. Deepa, and thank you for being a chair. Next is we have Dr. Archana Baser. Don't know if she has joined. Can we have the next slide? Hello, Nilima.
And the next, have to click on the slide. Yeah.
And the next chairperson, Dr. Archana, are you here? I'll just give her a call as well. Yeah. And the next chairperson is Dr. Anita Rajoria.
Yes, I'm here, Sita. Thank you. Thank you for inviting.
Thank you, Dr. Anita. She's the president ISOBAP of Delhi and a governing council member of our ICOG this year. Thank you, Dr. Anita. And we hand over the session to you to introduce the speakers. Thank you.
Thank you for involving all of us. So our first speaker is none other than Dr. Supriya Seshadri. She is the trained she is trained in obstetrical ultrasound at Fetal Foundation of India, and she is consultant sonologist, fetal medicine, gynae ultrasound. Madam will be talking about lexicon. What is the vocabulary of first trimester, especially when we talk in reference of bleeding in first trimester. Looking forward, Dr. Seshadri, for your presentation. Over to you, ma'am.
Good evening.
Is the speaker around? Yeah.
Am I audible? Now I'd like to, it says only one presenter can share at a time. So I'll press allow, or you all will press allow?
You can go ahead, ma'am.
Yeah,
Nobody's
sure.
sharing now, so you can share.
Are you able to?
Yeah. You can see my screen?
Not yet.
Yeah, you can go full screen.
Yeah, thank you.
It's fine now?
Yes.
Okay, so at the onset, again, good evening, and thank you, ICOG, for giving me this opportunity to speak. This indeed is a very passionate topic for me. There's early pregnancy, lexicon, and bleeding. Now, lexicon means a common language that ensures everyone means the same thing when describing something. And the purpose is to establish clear, logical, and respectful terminology to be used for diagnosis and management of first trimester pregnancy. And this entire talk, or rather the lexicon bit of it, is framed from this article of 2024. Now, back to basics. A patient is considered pregnant when the serum HCG value is greater than 5 milli-international units per ml. And I did think for a long time that it was 10, but the number now is 5. Now, the duration of pregnancy remains the same, the term, the gestational age, and this is reported as number of weeks and number of days. Of course, synonyms have been introduced, and they are menstrual age, gestational duration, clinical age, or clinical dates. And it is taken from the first day of the last menstrual period and or an early dating ultrasound examination. But what is important from this article is they mention that all measurements and timing of visualization of structures in early pregnancy are applicable to transvaginal ultrasound imaging. So when we send a request for an early pregnancy scan, we should avoid the term viability scan and instead use the term first trimester ultrasound or early pregnancy ultrasound. The reason being, Viability means ability of a fetus to survive in the extrauterine environment, and this is not applicable in the first trimester. When we do a scanning at early pregnancy, we get one of these findings. The first is an intrauterine pregnancy, and the definition for this is a pregnancy implanted in a normal location, that is the uterine cavity. Now, when we get a finding like this is an ectopic pregnancy, and the definition for this is a pregnancy implanted in an abnormal location, whether intrauterine or extrauterine. Now, ectopic pregnancy can occur in these various locations, but the lexicon mentions that when we report an ectopic pregnancy, the term should be preceded by its location. Example, tubal ectopic, interstitial ectopic. Not enough to say cesarean scar pregnancy. Must write cesarean scar ectopic pregnancy. But yes, I did kind of find a few challenges in the lexicon, and one of the challenge was note that they have used the abbreviation EP for an ectopic pregnancy. Now, when we get a finding like this, the term to avoid is angular or eccentric pregnancy, and this should be described as an eccentrically located gestational sac completely surrounded by the endometrium and should be reported as an intrauterine pregnancy. So the same goes for an intrauterine pregnancy in a Mullerian anomaly, where the GS is normally located in the right horn, in this case in the right horn of a bicornate uterus, and the reporting should consist of all these small findings as well. Avoid the term cornwall. When we get a finding like this, that is fluid inside the endometrial cavity which has a beak-like appearance, the term to avoid is a pseudosac. Instead, it should be reported as intracavitary fluid or fluid in the endometrial cavity. Now, at 5 weeks, when we see the gestational sac, yes, the lexicon has rightly defined it as round or oval fluid collection surrounded by a hyperechoic rim of trophoblastic tissue. Now, I have highlighted trophoblastic tissue in red because I am really pleased that the term choriodesidual is out, or at least decidual is out, because you find the term, decidual reaction being used a lot of times, and I did think that was incorrect. Now, when a yolk sac is seen, yolk sac is recognized by a cystic structure with a thin periphery. When a yolk sac is seen, it should be reported, the intrauterine pregnancy should be reported as a definite gestational sac or a definite pregnancy. On the other hand, when only a gestational sac is seen without a yolk sac, the reporting should go by probable gestational sac or probable pregnancy. When we see a gestational sac, yes, we take the mean sac diameter. The mean sac diameter is 3 orthogonal diameters in 2 orthogonal planes. But what I again found a bit of a challenge from the lexicon is they state that the mean sac diameter can be used to calculate the gestational age before visualization of an embryo. I will come to this point again a little later. Now, at 6 weeks, we do see an echogenic structure like adjacent to the yolk sac, and the term to avoid is an embryonic pole or a fetal pole. Instead, use the term embryo, and an embryo is an embryo till 10 weeks, 6 days gestational age. After that, it is termed a fetus. Now, when we see an embryo, yes, we measure the crown rump length, and the lexicon just gives it a very simple methodology saying the greatest dimension. Again, I think there will be challenges here. Now, when we see an embryo, we do note the cardiac activity, and the term to use is cardiac activity, cardiac motion reported in beats per minute, and only use the M mode, which even the lexicon states. Now, what should be avoided is the terms heart rate, heart motion, heartbeat. The simple reason being that heart is not really in its full formation at this stage, and therefore avoid the term heart. Also avoid the term live or life, living and viable, because this can, throw back a lot of emotions on a lady who's likely to face a pregnancy failure. The heartbeat starts at 90 to 110 beats per minute at 6 weeks. It rises steeply to a peak at 9 to 10 weeks at 170 beats per minute, and then gradually decreases to 135 to 145 in later gestation. Now, when it comes to dating, the same lexicon states that as soon as an embryo is measurable, the crown rump length should be used for dating since it is more accurate than the mean sac diameter. No doubt it is more accurate. Then what happens? Do we give two dates? Do we give two EDDs? And I do think this calls for confusion, this calls for a dilemma. And I personally would go by dating just using the CRL. Now, how to use the CRL? Use the best of the three CRLs. Redate if the discrepancy is more than 5 days at less than 9 weeks or more than 7 days at more than 9 weeks. In a twin pregnancy, use the CRL of the larger twin. In an ART pregnancy, use ET date minus age of the embryo correlated with the CRL. But the message is once assigned, the EDD should not be changed. And hence, I am really not a fan of using the MSD for dating. Now, coming to the next part of my talk, that is bleeding, PV, and early pregnancy. What are the differentials? One is a threatened miscarriage, early pregnancy loss, subchorionic hemorrhage, ectopic pregnancy, and a molar pregnancy. Let's look at all of these. A threatened miscarriage in an intrauterine pregnancy is where we see an embryo with a cardiac activity, the internal loss of the cervix is closed, and they may or may not be subchorionic hemorrhage. Early pregnancy loss, according to the lexicon, avoid the term early pregnancy failure. But here again, I think that the dilemma from the lexicon is they use the word EP here. So does EP stand for early pregnancy and early pregnancy loss, or does EP stand for ectopic? I leave it to you all to decide what works for you best. The term, what we can also say is spontaneous abortion and miscarriage, and the word abortion has made a comeback, but because I do recall, I think a 2016-2018 article which says don't use the word abortion. Now, the lexicon terms in a case of early pregnancy loss, what to use and what are the terms to avoid. The term to use is concerning for EPL. Now, EPL is early pregnancy loss or intrauterine pregnancy of uncertain prognosis. The term to avoid is intrauterine pregnancy of uncertain viability or suspicious for. Diagnostic of EPL, the term to avoid is diagnostic of pregnancy failure, blighted ovum, or non-viable pregnancy. Now, the term failure is not to be used because, again, it will throw back or the couple may go into a blame game and also find that they are inadequate to bear a pregnancy and a whole lot of unnecessary emotions. So that's why the term failure is to be avoided. Now, EPL in progress is inevitable, what we used to call it inevitable. Of course, it's not part of a lexicon article. And the other term is incomplete EPL or retained or residual products of conception. The terms to be avoided are intracavitary, embryonic, or fetal tissue. And completed EPL is the last of the segments of the early pregnancy loss. So let's take a look at each one of them. Now, concerning for EPL or intrauterine pregnancy of uncertain prognosis, the criteria on a transvaginal ultrasound are an embryonic CRL less than 7 millimeter, no cardiac activity, a mean sac diameter 16 to 24 millimeter, no embryo, and absence of embryo with cardiac activity 7 to 13 days following visualized gestational sac and no yolk sac, absence of embryo with cardiac activity 7 to 10 days following visualized gestational sac with yolk sac, an empty amnion sign, an enlarged yolk sac, a small gestational sac. This can be subjective, but if we want to be objective, then the difference between the mean sac diameter to CRL should be less than 5, or an absent embryo more or equal to 6 weeks after LMP. Now, any of these qualify for the terminology concerning for EPL. Now, these are just some representative images. So this is a large yolk sac, and this is what we call an empty amnion sign. This is the yolk sac, because once we see an amnion, we should see a live embryo inside. What is diagnostic of EPL? That is CRL more or equal to 7 millimeter, no cardiac activity. The other term that can be applied for this is an embryonic demise. Also, diagnostic is a mean sac diameter more or equal to 25 millimeter, no embryo, or an absence of embryo with cardiac activity more or equal to 14 days after visualization of a gestational sac and no yolk sac, or an absence of embryo with cardiac activity more or equal to 11 days after visualization of a gestational sac with a yolk sac. Now, the term and embryonic pregnancy has made a comeback because, again, there was an article, I think somewhere in 2016, 2018, which says don't use the term embryonic, but 2024 lexicon has brought a comeback for this term. Now, EPL in progress means a gestational sac in the lower endometrial cavity or endocervical canal and is in the process of expulsion. So this is a representative image wherein we see that the cervical midline is split and this is occupied by the gestational sac. However, before one makes a confident diagnosis of EPL in progress, we must rule out a cervical ectopic pregnancy. The difference being in a cervical ectopic pregnancy, the midline is continuous. There is a sac lying beside the midline in the cervical stroma, and also it'll have a blood flow, whereas an EPL in progress will not have blood flow. The other thing not to be mistaken for an EPL is a cesarean scar ectopic pregnancy, wherein we see the sac at the site of the previous cesarean section scar in a niche rather, and again the criteria for this is not surrounded by endometrium. Incomplete EPL, the other term for RPOC, is when we see, against a background of a positive pregnancy, either a spontaneous or an induced termination, we see an endometrial thickness. Of course, there is no cutoff for the endometrial thickness. Practically, we take a millimeter of 10 millimeter. We see what is described as an endometrial mass, in the sense the endometrial contour is undergoing a bulge, and what's more, we see vascularity inside. But what we must note that absence of all the three findings has a 100% negative predictive value, but the false positive diagnosis can be as high as 25 to 40%. Now, completed EPL is when this complete passage of the gestational sac and chorionic tissue from the uterus following an EPL. But the requirement is there should be an early ultrasound examination with a documented gestational sac or even with an embryo. Subchorionic hemorrhage is another very important cause for bleeding. Now, whether the bleeding results in subchorionic hemorrhage or subchorionic hemorrhage results in a bleeding, it doesn't matter. But it matters how we recognize it, and that is a collection of blood between the chorion and the myometrium. And this is a crescent-shaped or curvy linear collection which conforms to the contour of the gestational sac. The echogenicity varies with the age of the bleed. In the acute stage, it is hyperechoic. When it is subacute, it is heterogeneous. And then in the chronic phase, it becomes hypoechoic or anechoic. Almost 70% of the hemorrhages resolve by the end of the second trimester. Now, why we should note, yes, because the meta-analysis has brought about these risk factors. There's an increased risk of miscarriage, preterm birth, fetal growth restriction, placental abruption, and not a significant association with preeclampsia. The same meta-analysis stated that due to inconsistent grading standards, inconsistent standards for intrauterine hemorrhage size across studies, there was insufficient data to assess its impact on prenatal complications. But there's conflicting evidence as well. Now, these authors state that subchorionic hemorrhage increases the miscarriage risk with vaginal bleeding, but does not affect the outcome of ongoing pregnancies. These authors state that it is not associated with adverse outcomes after 20 weeks, and there's no association with first trimester miscarriage, but there is an increase in preterm birth. Now, what are the risk factors? The risk factors are maternal age more than 35 years, age of diagnosis of less than 8 weeks, and what is called a wrapping subchorionic hemorrhage, wherein the hemorrhage is seen adjacent to equal or more than 2 walls of gestational sac. And in this scenario, the risk is as high as 61% vis-a-vis other locations, that is purely anterior, purely posterior, or lateral. Now, although studies say, yes, size doesn't matter, because we take size, what is the best way to take size? Various methodologies are there. Some take the mean diameter, some take volume, and some take the subjective assessment. The best, according to this study, is a subjective assessment of the size of the hemorrhage vis-a-vis the size of the gestational sac. Mind you, it is subjective, but expressed as a percentage. So small is when it is less than 25% of gestational sac. There the risk of miscarriage is 18%. Moderate is 25 to 50%. Risk of miscarriage being 21%. And more than 50% is large, where the risk is about 21% again. Now, in an early pregnancy scan, we do come across these findings. These are indicative of an ectopic pregnancy, but what are the terms to be used? Avoid the terms blob, bagel, donut, because they're vernacular terms. Rightly agree to that. Instead, use the words extra-ovarian mass or an adnexal mass, or a tubal ring or an adnexal ring or an adnexal gestational sac. Now, when there is no yolk sac or embryo in a tubal ring, we should report it as probable ectopic pregnancy. On the other hand, when we see a yolk sac and a fetal pole, then we should report it as a definite ectopic pregnancy. Having said that, the lexicon also goes to state that if we are reporting an ovarian ectopic pregnancy, it should have a yolk sac or a fetal pole. And avoid here again the terms live, living, or viable. Now, coming to the last category for bleeding is molar pregnancy. Although it is said that these hydropic villi cannot be seen early, I do think with the machines that we are provided with these days, we can pick up a molar pregnancy. And this was as early as about 8 weeks, which turned out to be a complete mole diagnosed by the presence of these cystic areas in the trophoblast. Now, the snowstorm appearance is only seen around 11 weeks. Of course, do not mistake a hydropic change in a miscarriage to be a complete
Sorry to
mole.
interrupt
Here
you.
again,
Time is up.
sorry? Yeah, I finished. Here again, the thing is to do a beta HCG. It'll be very high in case of a molar pregnancy and not so high in cases of a subchorionic hemorrhage. So in conclusion, use the right terminology because it provides effective communication to both patient and other clinicians. The order of appearance is a gestational sac, yolk sac, embryo with a heartbeat and an amnion. Miscarriage is a MSD more than 25 or a CRL more than 7, no heartbeat. Prognosticators are an SEH, small or low GS abnormal yolk sac, and use M mode. Be wary of the worst case scenarios in bleeding PV, such as ectopic pregnancy and molar. I always like to leave my early pregnancy talk with this statement by Professor Blas made in 1999 that the ultrasound examination of the early pregnancy complication should not be solved by the young first-line doctor. I would say that early pregnancy should not solved first time by the first-line doctor. So thank you very much for a patient hearing, and I apologize if I've exceeded time.
No, not at all, Supriya ma'am.
Thank
It
you,
was a
Supriya.
lovely presentation.
It is
No,
excellent.
ma'am.
I mean, listening to you on early pregnancy scan is always, it's like it flows. And the most important thing, just to take home from my side for this, is whenever there is a subchorionic hemorrhage, don't write off the pregnancy because not every women with subchorionic hemorrhage will lead to miscarriage. So very, very well said that it should not be done by the first line doctors since it's an early pregnancy scan and it's very easy. You can just put in a transvaginal probe and do it, but it has to be assessed very well because this is the foundation of full 9 months of pregnancy. Thank you very much.
Thank you. Thank you.
I'd just
We have
like to
with
add,
us our
ma'am,
guest of
yeah.
honor.
Yeah, thank you
Yeah.
and welcome, Dr. Archana. May we please welcome our guest of honor, Dr. Meera Agnihotri is here. Thank you, Supriya, Dr. Supriya, for that wonderful talk.
Excellent talk, Supriya, I must tell you.
Yeah.
Yeah. New terminology.
Thank you. I think Dr. Meera Agnihotri, welcome Professor Dr. Meera Agnihotri. She needs no introduction. She's a teacher and an inspiration for all of us at FOGSI. She's a professor and head of the Obs and Gynae department at the Medical College Kanpur and presently chairman of the Ethics and Research State Medical Council. She has to accredit multiple awards and
with the academic program.
and thank you, madam, for joining. And maybe please have your blessings, your words of wisdom and your blessings, madam, for our masterclass. Thank you.
It's a real honor and pleasure for me to join this ICOG masterclass on ultrasound in obstetrics and gynecology, which looks very easy, but one of the most tough subjects which we have to calculate and come out with it. I heartfelt thanks to ICOG chairperson, Dr. Sheila Mane. Kindly accept my regards, Dr. Aishar, Dr. Sadhana Gupta, Dr. Suvarna Khadilkar, I can't see her, dear Prateek, and Sita, thank you very much for inviting me. The speakers like Chinmay Rathe and Kanchan Prasad, they will really. I will not like to waste any moment for anything. Sita, I know that the academic involvement of Indian College of Obstetrics and Gynecology, headed by one of my favorite persons, that is your husband, and Dr. Sheila Mane, they will really make difference. I always know that they are great academicians, zameen se jude hue, no pomp and show, nothing show off, but only academic and academics and academics. So I personally feel, I extend my heartfelt gratitude to Dr. Sheila Mane, Dr. Bhaskar, Ashok Kumar, Dr. Sadhna, Suvarna, and Pratik Tambe, whom I keep meeting, and I think we have met only a couple of days back, and we know how important these meetings are. And the subject which you have chosen is a very, very important subject. I really wanted to see the process of reduction, which has undergone lot many changes in the past years. So it must be a lesson to the beginners also. Thank you very much. I congratulate all the speakers, Dr. Chinmay, Bela, Dr. Ghosh, Dr. Gopinath, Dr. Suresh, and Sri Devi Kohli. Kindly accept my congratulations. And Sheila, please keep on calling me.
Yes.
I will love to be there.
Yes,
And
madam.
Sita is already there. So there is nothing to add and nothing to say. And whole body governed by one of my favorites, that is Bhaskar. So I personally feel that we are going very high in a vertical direction, not only in the slanting direction. Thank you very much for calling
Sir,
me.
madam, I am also your favorite.
I know you are always my favorite. Bhaskar and you, I have taken two names. तुम्हारा नाम छूट गया क्या?
नहीं
मैंने
नहीं
भास्कर और शीला दोनों
मजाक कर रही
कहा.
Sheila madam, please say a few words and talk Pratik.
Right.
Yeah.
So
Okay. Thank you, madam.
शीला माने का फर्स्ट लेक्चर कानपुर में हुआ था, and it is on record. We have got that record also. I don't know whether she remembers it or not, but that is on record and hugely attended. You see, lot big audience, lot big applaud, and she's an academician. Everybody knows. She's an academics and think academics. Much. Keep calling me. I will love to be with you once again. Thank you.
Madam, it is always a pleasure meeting you. And I must say that you people are seniors and you are real strength for all of us. The way you
Am I
show
audible?
affection, the way
Yes,
you people show us the affection and the way forward. I mean, it's amazing. Just now I met you in UP conference. कितना अच्छा लगा आपसे थोड़ी देर के लिए बात हुई. But you are there always to encourage us, and that is real strength of our ICOG as well as FOGSI. Thank you very much for accepting our invitation and being there as our chief guest today, madam. Thank you. Pranam.
Is madam there?
I think there's some internet glitch.
Yeah. We welcome Dr. Sadhna Gupta as well. I think Dr. Ashok Kumar, I don't know if he's joined. But yes, you can continue, Dr. Dr. Anita and Dr. Archana and Dr.
Yeah. Good evening, everyone. On behalf of FOGSI ICOG, it's my great privilege and pleasure to welcome and introduce our esteemed speaker for the next talk, Dr. Vandana Bansal. She is a highly respected clinician, academician, and teacher in the field of fetal medicine and obstetric ultrasound. Today, we have the privilege of learning from her vast experience and practical insights in ultrasound. We are looking forward for an enriching, informative, and immensely beneficial talk by Dr. Vandana Bansal on first trimester screening. Over to you, Dr. Vandana.
Thank you so much, Deepa, for the introduction. And thank you, ICOG, for calling me here for this lecture. While I am speaking, let me share my screen. Yes. So the topics today are very interesting, all of them. And the topic given to me is on first trimester screening. So in the next 15 minutes, I will try going through basics of how we do first trimester screening, what exactly is done. So let me go forward with this, that we always have this kind of timelines. So our first trimester screening is done between the 11 to 13 plus 6 weeks. When we, in addition, look at gestational age, viability, twins, chorionicity, as just now the previous lecture spoke about. But it is a very good window for screening for aneuploidy, as well as to look for preeclampsia. And also we do a lot of anomaly screening at the same time. So we used to not offer this down screening for all earlier, but now it is being offered to all, and it should be done for everyone, whether she is 20 years old or she's 40 years old. The risk for down maybe is more in 40 years old, but yes, a first trimester combined screening has to be offered to everyone, independent of maternal age. And what this Langdon Downs saw, these babies which had a very small nose and a very thick skin, was then interpreted by Nicolaides as increased nuchal translucency and an absent nasal bone. And that is what has changed our system, that we have started now triaging everybody at 12 weeks. So this 11 to 13 week scan triages them into high risk and low risk. And the ones where everything is normal, we would directly call them at anomaly scan, while where there we see problems, we would send them to specialist care. And so before we do any kind of a first trimester screening, we absolutely require to establish the gestational age. So either it is by the LMP if there is not a discrepancy of 5 days, or by the CRL if there's a discrepancy of more than 5 days, then we would redate the pregnancy and follow this date always. Why this is important is because all your screenings are dependent on the CRL. So that is why whatever screening we do, our dating has to be accurate. And for that, the most important part of the first trimester screening is our nuchal translucency between 11 to 13 plus 6 weeks. And this has to be done at a CRL of 45 to 84. It has to be ekdam typical mid-sagittal. When you are seeing the nasal bone, the tip of the nose and the chin is seen, and there is some space between the chin and the torso. And it has to be a zoomed up image which covers almost the head and the torso, and a neutral position. So if I take only a nuchal translucency itself, it has a detection of almost about 80% for trisomy 21. Why we don't do it before 11 weeks? Because one, it could cause procedure related problems. If I will do a NT earlier, I might do a CVS earlier, and limb reduction defect. And yes, we can see malformations better at around 12th and 13th week of gestation, and not beyond 14 weeks, because one, the NT can become normal after 13 weeks, and second, the baby becomes more vertical and it becomes difficult to get an NT. So the standardization has only been done between 11 to 13 plus 6 weeks. So as I said, here you can see this image which is correct, and the other image I cannot see the tip of the nose, so it is not a mid-sagittal plane. And if I have a mid-sagittal plane, they should be rectangular palate, and they should be in absence of the maxillary process. In addition, the thalamus, midbrain, brainstem would also be seen in the same plane, and IT will also be seen in the same plane. So these are the points which have to be seen when you are taking an image, and then it is a standard image that we have. If there is any flexion or if it is extension, again the NTs are not correct, and it has to be a neutral position to be taken for this NT. Also, we need to see where is the skin and where is the amniotic membrane. So you have to be careful. You are not measuring the space between the amniotic membrane and the skin. It has to be on to on and from the skin to skin. So it has to be measured like this. And if there is a membrane below this, that is not to be measured. So why I brought these up is that whatever standards that we are looking at, it has to be as accurate as what is there in the FMF guideline. And sometimes when you have a umbilical cord around the neck, even in the first trimester, you might see two sides and nothing seen in the area of the cord. And so you can then average from both the sides. So when I have an increase NT, what do I call it increase? Is anything which is more than 95th centile. You will have to put it on the CRL chart to see what is the centile. So at 45, even 2 is 95th centile, and at 85, it is more than 3 is positive. But for every time, any weeks of gestation, more than 35 is always abnormal. So this cutoff that we use, more than 3.5, is for any weeks of gestation. But yes, it has to be evaluated as per the CRL. And if I see an increase NT, I would not only be worried about Downs, I'm also worried about cardiac abnormalities, skeletal problems, genetic syndromes that can happen. So now, if there is an increase NT, whether septation is important or not, whether if it is confined to the neck or it is enveloping the whole fetus, it is increase NT is increase NT. It doesn't matter how the physical appearance is. It is the size of the NT which is important, and that has to be taken. Our own study of 500 plus cases where we looked at NT above 95th centile, where 19% had some kind of an aneuploidy seen. So when we've done a good accurate NT, what else do we add on to is a maternal age and a dual marker. This combination has a detection of 90% for trisomy 21 for a false positive of 5%. So this is a good test which is available, and this includes a beta HCG and a PAPE. So if to remember, H is high, so trisomy H is high and PAPE is low. So there has to be both 1 mom to call it as euploid, and for trisomy 13 and 18, both of them have to be low. So what else do we add on to this first trimester screening? Does it help us? Are these soft markers that we have, of which the nasal bone is to be taken in the same plane as you take your NT, and with the same tip of the nose seen, and you can see these two equal sign, and the second equal sign has to be very thick and echogenic nasal bone. Then we will call it as present or absent. Again, absent nasal bone has a detection of almost 60 to 70% for trisomy 21. So we add this to our screening test, and our own experience also says that it will increase our detection rate for aneuploidy. Then we add on a ductus. So this is the vessel going to the direct to the heart, and if there is a ductus reversal, again it is a marker not only for trisomy 21 but also for cardiac abnormalities, and also sometime associated with FGR as well as perinatal death. So if you have a reversal in the ductus, one, think of aneuploidy, but think of a lot of more things also. Similarly, a tricuspid regurgitation. So this tricuspid valve is to be put, the sample volume has to be put in the tricuspid valve, and you look for this regurgitation. If it is more than 60 centimeter, then it is significant, and it should be present in at least 30% of all the contractions. And again, it is a marker not only for trisomy 21, Turner, 13, 18, but also for cardiac abnormality. When I add all of these, the maternal age, the NT, the nasal bone, the ductus, the TR, and the dual marker, I put all of them together and I call it as a combined first trimester screening. And this has a detection of as much as 95% for a false positive of only 2.5. What else can I see in this NT scan? We will talk about it in the next lecture that we have. But yes, we also look for malformation, and also a uterine artery Doppler to see for preeclampsia, also for pregnancy, any complications, and for multiple pregnancies. But that is a part of the next lecture that we have. So our own publication, when we looked at the various invasive procedures done, if it is only biochemistry, then only 2% are true positive. While if there is some structural abnormalities in the ultrasound, then our true positives are much higher, as much as 12%. So when I see new structural abnormalities during the first trimester or during the second trimester, I will be more wary of this coming out as abnormal. So now let us look at what screening cutoff do we take. So our conventional screening cutoff was 1 in 250. So if it is higher than 1 in 250, I will call an invasive test. And if it is less than 1 in 250, I would call it as a low risk screening test. But now with the NIPT which is available, either we could do a NIPT as a primary screening test that I offer NIPT to all, but it is a good way to improve our detection rate as well as reduce the number of NIPTs that are being done by this secondary screening process. So what is done is, if we have a good scan, which is normal, but a first trimester screening has come as more than 1 in 100, then I will offer an invasive test. And if it is more than 1 in 1000, which is very low, I will call it as low risk. But everything what is between 100 and 1 in 1000 is the one where I will offer them an NIPT. So if this NIPT is normal and structurally the baby is normal, we will take it as low risk and no procedure. And only if NIPT is high risk, I will add them into the invasive procedure. So this is a good way of improving our detection rate without doing too much of NIPT, the cost involved. And wherever there is an invasive, then we would do our CVSs or an amniocentesis or a cord blood sampling wherever it is required. So now let us go on from here to twin pregnancy. So do we offer screening for patients who are twins, and especially what are the prerequisites? So the first, as I said, for singleton also, you have a dating which is important, and for natural conception, the CRL of the larger twin is taken as the dating scan. And if it is an IVF, then we know the embryo transfer date. Again, here it is important that we date, because all our screening will depend on that. Second most important is to look for the chorionicity. A DCDA, an MCDA or MCMA is very important to assess prior to us sending for a screening test. What more is important is to label them, because you could have the one on the left, one on the right, or up and down. You have to add on to that the placentas as well as the cord, so that we are sure which fetus we have screened, so that when we require them for a reduction, if required, after the procedure, then we are sure which one are we doing. So we start from the lower end, then we go clockwise, and then the clockwise one. And so that is how this goes anti-clockwise. So lower, then upper left, and then upper right, and then lower right if there is more to it. So now, which is the optimal screening test for twin pregnancy? So the same detection of all the markers together, the detection rate is slightly lower than singleton, but not so bad. So for a DCDA, it is almost 86 to 89%, and MCDA little better at 89%, while what we said for a singleton, it was around 95% for this kind of a soft marker. So if I have a MCDA twin, then I will take it as risk per pregnancy. That means there is only one risk which will come. But if it is a DCDA, we will get 2 reports. So there will be risk per fetus that is there. So here you can see this is a twin peak sign. So it's a DCDA twin. So here, if you will see in the report, you get 2 reports, one twin 1 and one twin 2. While if I have something like this, which is an MCDA twin, then you get only 1 report, because there are 2 entities. Beta HCG papae is same, but the risk is 1, because there is a similar genetic material in both of them, and you get 1 report. So what is the optimal screening test in patients who are triplets and above? So in this patient, we had 3 of them. And so here there is only an NT-based screening test should be done in triplets and above, and not any other biochemical markers. What do we do if there is a fetus which is reduced inside or has spontaneously vanished? If there is a CRL inside, it will impact our screening test. And so we will only do an NT-based screening test, that is NT, nasal bone, ductus, and TR is what we will look at, because it is the papae which gets altered. So there is now a new concept that we use the age, NT, and only the beta HCG for patients where there is a CRL which is already seen. If there is no CRL and it is 8 weeks from the vanishing twin, you may use the biochemistry. This is a molar pregnancy with the fetus, and again, no biochemistry to be done in these cases. Can I do quadruple in these cases? I am finishing in a minute's time. So in quadruple test also, in twins, it is not a very good test. So best is to do first trimester. But yes, if there has not been anything, you might do, but the detection rate is not very good. What is better is to do an NIPT in twin pregnancy if we have to do. The screening performance in twins is slightly lower than singleton, but it is much better. It is much good for MCDA twins rather than DCDA twins. The failure rate is slightly higher for these cases, but it is still a good test to use for twin pregnancies. And even in the first trimester or in the second trimester, NIPT is a good test to offer for these patients. So I will stop at this because my time is also over. And thank you, team ICOG, for calling me here and making me speak on first trimester screening. Thank you, Pratik. Thank you, Sheila madam.
Wonderful presentation, Dr. Vandana. It is a pleasure always to hear you, ma'am. All the slides have been wonderful, and every slide has some or other carry home message. Thank you for highlighting the importance of first trimester screening, ma'am. Now we can go on to the next session. Deepa, will you introduce, or Archana ma'am is there? We can go on to the next. Ma'am, I'll request you to kindly answer any question if there are any in chat box only.
Yes,
So
I'll do that.
yeah. So for audience, you can share your queries in chat box and our learned speakers will answer them there. So we can go on. Nilima, we can go on to the next speaker.
Can we have the CV of Dr. Sita Pal, ma'am?
Yeah.
We welcome Dr. Sita Pal, ma'am.
Thank you, Dr. Deepa. It's okay. I think we'll move on with the session.
We must introduce you. You are the first lady of FOGSI and a
Yes,
very
ma'am.
dear friend, Sita.
Thank
She
you.
has
No,
a
that's
plane to catch also.
Yes. And I'm having some issues with sharing my Zoom as well with my Zoom. So I'm just requesting Nilima or Chinmay to see if they can share my PPT. Thank you, Dr. Anita and Dr. Deepa and Dr. Archana. At the outset, of course, a big thanks to our FOGSI president and and Suvarna Khadilkar, Dr. Sheila Mane, our ICOG chair, Dr. Pratik Tambe, our secretary. Any luck, Shreya or Chinmay? I'm not able to share.
Yeah, I think I'll share my screen. I'll just get on. I've got the PDF part sorted out.
Thank you. Thank you.
Just 1 minute. Just 1 minute.
Yeah.
All kinds of things will happen at the same time. Just 1 minute.
So we have 500 plus attendees live. It's very heartening to note, and we had over 400 right from
Can
the
you
very
see
first
the
talk.
screen?
Not yet.
Yes.
Yes.
Yeah.
Thank you so
Okay.
much.
Please let me know so I
Yeah,
will
yeah.
change accordingly.
Thank you. So, yeah, next slide, please. So, after that wonderful talk on the lexicon of first trimester terminologies and in the screening, we are moving on to what first trimester now has in scope for, scores stored for us, because we've moved beyond the screening and we are looking at the morphology. So, next slide, please. That's me for you. Thank you very much. And then, so congenital malformations actually form a whole group of 3 to 5% risk of major malformations, with 10% which are minor in nature. And of course, with the increasing ultrasound machines, with the man behind the machines and the different features that we have in the machine, we are identifying more and more anomalies much earlier as well. And of course, we are able to take that with the genetics etiology as to see what exactly we have. And the main important thing is to put these phenotypic features which can be identified prenatally and give it a cause for this, and so that we can mitigate recurrence. Next slide, please. So, next slide. Next slide, Chinmay. Yeah. So in India, we account for about 1/4 of the neonatal deaths globally for major malformations, where 1/5 is mainly congenital malformation, and 5 million births actually have in 2017 have been affected with congenital major malformations. Next slide, please. So anomalies can right now, I wouldn't say we have been performing it earlier between 18 to 20 sort of 22 weeks or 23 weeks. But with the MTP Act being in place, and we are having enough time for us to act, even terminate pregnancies up to 24 weeks. We have moved from 18 weeks to around 19 to 21 weeks, so that we finish our anatomy scan by 21 weeks. And this actually represents a compromise between dating, and which is more obviously done if you have dated it accurately, as we've heard earlier, and the timely detection of major anomalies. But there is evidence that delaying the anomaly scan later until around 20-21 weeks actually increases the likelihood of obtaining satisfactory images, and then you can identify those problems which are actually incompatible with life. Next slide, please. So as we've seen that the pyramid of care has changed, and we are moving, at the Fetal Medicine Foundation, which has suggested the pyramid of care where we triage all these women at 12 weeks, and then depending on their risk, we decide whether they can go into specialist care or routine care. Next slide. So the first trimester is actually a big crucial window of opportunity where we screen for maternal problems, and we also have very important landmarks for fetal evaluation, which actually forms the base of our pyramid. So next slide. So here in first trimester, we have an early first trimester ultrasound up until 8 weeks or 9 weeks, where we've seen all the problems or the normal features. But there is something called a late first trimester ultrasound that is between 11 to 13 weeks. And if economically feasible, if one ultrasound is done in the first trimester, this would be the ideal one, where you can screen for aneuploidies, you can assess structural defects, you can screen for all the abnormalities, especially nudal tube defects, also screen for preeclampsia and preterm birth. We are going to concentrate mainly for structural defects. Thank you. Next slide. So in first trimester, when we're looking at anomalies, the factors that actually affect the detection rate is the gestational age, very importantly, because if you see very early, some of the features might not be seen. And as you go later, obviously the things are much more developed. The physiology of the fetus also develops. And it also depends on which mode of ultrasound you're using, transabdominal and transvaginal, because transvaginal, actually the clarity is so good in the first trimester. The features are very specific. And of course, if you add 3D, that also has a big advantage. The operator experience matters, and I said machine quality makes a difference. But whatever it is, we should have a standard protocol and guideline-based approach. We should have a checklist, as we do in the second trimester, also for the first trimester. Next slide. So in aneuploidy screening, I'm not going into the details. Can the video run, please? Chinmay? Oh, that will be sad if the videos
This is the
don't.
PDF, so that won't run.
Oh, I'm so sorry. So this was full of videos. Anyway, there was a midline sagittal section of the fetus, and we've heard all that magnification has to fill most of the screen. The fetus has to be in neutral position. And obviously there is a clear guideline as to how we do the screening for aneuploidy between 45 and 84 that we've seen. Next slide, please. It's going to be a bit of a letdown if obviously the videos don't work. Next slide, please. So as we said, the detection of anomalies varies according to gestational age. And so if you do it earlier, between 45 to 62 millimeter, by transabdominal, the detection rate is around 22%. Whereas if you add TVS and 3D, it can go up to 45%. And for a CRL of later, between 12 to 13 weeks, that is for a CRL of 63 to 84, the detection rate can go up to as high as 84% when you use transvaginal and 3D. So it is important that if you suspect anything, or for a full evaluation of the fetus from head to toe, it is better to combine transabdominal and transvaginal and use 3D if required. Next slide, please. Yeah, so this is ICOG. Our Bible has actually shown us the different checklists that we have, and this is again a video which we go from from head to toe. Where head, we look at whether it is present, the cranial bones, the midline falx, and then the choroid plexus filled ventricles, which is the typical butterfly sign that we see in the first trimester. Neck, whether it is a normal appearance of the neck, and of course the nuchal translucency along with it, and the face, eyes with the lens, nasal bone. This is taken from the ICOG chest list, where we look at every organ the same way as we look in the second trimester, but with certain limitations, that's saying that the brain may not be developed at this stage, but most of the other organs, like the spine, both in 3 sections, longitudinal, axial, and transfer, and coronal with the intact overlying skin. Chest, we look at the symmetrical lung fields. Heart, whether there's regular 4 chambers with, sometimes we can look at the outflow tracts as well, very clearly in later gestations. And also the most important thing in heart is whether the axis is deviated or not. In abdomen, where the stomach is present in the left quadrant. So we start in the same way as situs as we do it in the second trimester. Look at the bladder and kidneys. Abdominal wall, we look at the normal cord insertion, whether there are any umbilical defects. Extremities, 4 limbs with each 3 segments. In fact, in the first trimester, the extremities can be seen very, very clearly. And of course, not to forget the placenta and the cord, whether it is a 3 vessel cord, and the size and what is the structure and location of the placenta. Having said that, we never label the placenta as low lying in the first trimester because it is still a pelvic organ. And please don't call her as a placenta previa at this stage. We need to call her back later. And in of course, when you're doing the anatomy scan, if it still persists, then maybe at that point you will be designated as a low lying placenta. And here is the checklist that again ICOG recommends, where you have all the organs and you tick it. So it is better, and these are the typical images that you are expected to look at as you do it in the second trimester. The same goes in for the first trimester as well. Next slide, please. So again, these are videos where we look at normal head. I'm afraid this is the 4-chamber heart with the outflow tracts and the 3-vessel view and the 3-vessel trachea view. You can see the limbs here. Actually, I'm afraid you will not be able to appreciate. But these are the structures that we do normally see from head to toe going in a sequential manner. Next slide, please. So this is aneuploidies, where we look at, this is a video of hydrops, where there is fluid around the neck and as well as the entire structure, entire body of the fetus. And more commonly, if you see this, that they do tend to miscarry in the first trimester. But of course, when you see them, you have to find a cause. And most of them are associated with monosomy X, Turner syndrome. And the challenge here is whether you need to terminate them and then do a genetic testing, or whether you do antenatal testing. Of course, the idea is to get a living cell. So it is always better to do antenatal testing when the fetus is alive. But if the patient wants to terminate, you can always do that later, but never send a karyotype, because that will not give you living cells. You will need to do a chromosomal microarray. Next slide, please. So this is again a trisomy 13, where there is holoprosencephaly, and as you say, by transvaginal ultrasound, the images are much better. You have, a midfacial hypoplasia with thickened buccal translucency, but these can be diagnosed very early, and these are some of the anomalies that should not be missed. So if it is trisomy 13, then it is usually the recurrence risk is low. It's usually a sporadic, and the recurrence would be around 1% as in the general population. Next slide, please. In head, again, as I said, these are when you go step by step, we have the cranial bones, the midline falx that completely divides the head into 2 equal hemispheres, and the choroid plexus is the typical nice butterfly that we see. And if there's any, we also look at the aqueduct of Sylvius. Next slide, please. With no images. Yeah, we look at this is a picture from the Ravi Chavi's book, where we look at 3 planes. This is more clearly explained. That is the 2 ventricles with choroid plexus filled, the aqueduct of Sylvius, the thalamo-peduncular view, where we look at the peduncles, whether they are converging or not. And then we also look at the cisterna magna and the 4th ventricle. So in one section, the transverse and the sagittal section, we can actually have a picture. Next slide, please. Next slide. Yeah. So these are sorry, that's the previous one. Yeah. These are anomalies where this was a picture of anencephaly, which ideally should be picked up by 10 weeks. Earliest we can pick it up. It's sad to see that they are still picked up in the second and late trimesters. This is a specimen of an encephalocele, where we look, if they are encephaloceles, you have to see whether there's a syndromic association, whether there is any Meckel-Gruber syndrome, because if there is any polycystic kidneys or polydactyly. Again, this was one showing an occipital encephalocele with hydrops. Next slide, please. Moving on, we've moved on to look at detection of first trimester neural open spinal defects by the first ultrasound, where Dr. Ravi Chavi has come up with the intracranial translucency. So if that is obliterated, we can suspect open neural tube defects. Sometimes we can see it as well, but if there is any suspicion, you can always call the patient again at around 14 to 16 weeks, confirm the diagnosis, and then decide whether the fetus needs to be terminated or not. Next slide, please. So in neck, we look at the normal nuchal thickness. This is a video showing, and we typically look at the nuchal translucency, as Dr. Vandana has very beautifully explained. But beyond this, we also look at any swellings. The next slide, please. Behind the neck for any cystic hygroma. And these are the, so one sagittal section can tell you about the different anatomical structures like thalamus, midbrain, the intracranial translucency, the cisterna magna. If it's increased, you might suspect a posterior fossa abnormality. And of course, we look at the nuchal translucency as well. Next slide. So here we look at the eyes and the nasal bone with a premaxillary triangle. We can make out lips, and typically we can make out the lenses and the mandibular gap that is seen. This is also a video which shows that the normal mandibular gap is there, and that if that is absent, we can suspect retrognathia or any other facial abnormalities. Next slide. So this is a case of a trisomy 21. There was increased nuchal translucency, there's absent nasal bone, and with reverse ductus flow in the ductus venosus, that confirms nuchal trisomy 21. So these are the ones which will need confirmation, and then the couple can decide whether they need to terminate or not, or carry it forward. Next slide, please. In chest, we look at the symmetrical lung fields with no effusions or masses. Next slide. And this is a case of bilateral pleural effusion and a congenital diaphragmatic hernia. Again, the videos are not there, but this can be seen. Next slide. In heart, we have the regular activity of the heart. We look at the axis, because one of the earliest signs of cardiac abnormalities in the first trimester is an axis deviation. So even if you can't see the anomaly per se clearly, axis deviation is something which you should be highly suspicious and call them for, if you can do a transvaginal, and call them for a ultrasound earlier than later. Next slide. So some of these anomalies can be detected. This is a typical U sign where there is a right aortic arch, and you can do a screening or diagnosis at that point to check whether the fetus has evidence of DGeorge or 22q11 deletion. Next slide. In abdomen, we see the stomach, which is in the left quadrant. We look at the bladder and the kidneys. Next slide. And we also look at, this is a video of an exomphalos, which involves the liver. And this is a typical megacystis, which we will measure. And if it is anything more than 15 millimeter, there are typical criteria for that. If there's anything between 7 to 15, we would say it is more related to chromosomal abnormalities. Where if it measures more than 15, it is more likely to be a mechanical obstruction and more severe prognosis. Next slide, please. With extremities, as I said, this is again a video where we show 4 limbs with each of the 3 segments, and the hands and feet can actually be seen very, the fingers and the toes can be actually seen very clearly in the first trimester. So this is the best time to see the limbs. Next slide. So here is one with an tripartite hand, which is a trident hand, sorry, and that itself tell you that this is a genetic problem when you start looking for other abnormalities. In spine, we're looking at the skin, overlying skin, and typically if you can see an occipital encephalocele, you also, as I said earlier, you start looking for other abnormalities to see if there is any genetic associations. Early signs of skeletal dysplasia are there, or triploidy, where the head measures very large compared to the abdomen or the rest of the fetus, and you can see sometimes even if there is gross, severe, lethal skeletal dysplasias, the limbs will appear very, very short, and they will be much less than the first centile. This was a case where she was a non-consanguineous couple where they had multiple pregnancy losses with neonatal death, and then 2 babies had died with abnormalities. It was investigated, and then they found a rare gene, COESI gene, that was found. When they came back to us, next slide, please. Sorry, that slide is not there. Anyway. Yeah, this was the one where they came back to us, and before we could diagnose in this case, the baby already had severe hydrops. This is again a video. So sometimes we really cannot help much in these cases. We really have to go in for a egg donation or some other adoptions. So when we are screening for structural defects, it is important to remember that certain anomalies can be detected 100%, like acrania, anencephaly, and encephalocele. There is a detection rate of 50 to 99% for cystic hygroma, gastroschisis, megacystis, and even HLHs. But in terms of other anomalies, the detection rates go down, and especially in brain anomalies and the evolving anomalies which evolves with the physiology of the fetus, the detection rate can be low as 0%. And this is what the systematic review said. So it is important to remember that though we are looking for anomalies, we cannot completely detect all of them. It is important to tell them that there are evolving anomalies which can come up in the second and even later in the third trimester. So as we said, the first trimester gives a window of opportunity because you can suspect and even detect major, which are lethal anomalies. We can reassure the couple accordingly. If there is any issue, they can do a genetic diagnosis early and do a specific genetic test. And if suspected, you can confirm at 16 weeks and terminate the pregnancy early if required. Thank you for your patience. Really apologies for that, as I couldn't share the videos, but that was some fault of the Zoom.
It was a wonderful presentation. But we really missed the videos.
We really missed your videos. It was our hard luck, but anyways, some other time. It was a wonderful. I just want to say that a good first trimester ultrasound done in expert hands can detect so many structural anomalies, and it can lead to some clue regarding other underlying other syndromes or other other triad of other symptoms or signs. So it can give you some suggestion what test next to be done. So thank you for that wonderful presentation. Yeah.
Thank you. And thank you.
Talks by all three speakers in the first session. Thank you very much for all your hard work and efforts. Thank you, Dr. Sita, despite being traveling today and getting delayed for the airport. You still did justice to your talk. Amazing. Thank you very much.
Thank you. Thank you, Chinmay.
Thank you for the opportunity, ICOG team. Thank you.
We have with us Dr. Sadhana Gupta.
Tomorrow morning.
Yeah, see you, madam.
We have our Vice Chair of ICOG, Dr. Sadhana Gupta. Madam, would you like to speak before the next session starts?
Brilliant talks, Dr. Supriya, Dr. Vandana, Sita. We always look forward, and ultrasound, it's about just observing and reflecting. And all three speakers did so well, and looking at the images. We really miss Sita's video, but it was all the session was, three sessions were wonderful. So thank you for being with us, all the experts. Thank you for being with us.
Thank you all the speakers of first session and chairperson. And now we can move on to the next session. And at the outset, I would like to thank Sheila Mane ma'am, Pratik Tambe sir, and Sita ma'am for giving me opportunity to moderate and co-convene this program. And for the next session, which is on second and third trimester ultrasound, we have learned speakers, Chinmay Ratha ma'am, Bela Bhatt ma'am, and Kusagrathi Ghosa. And we have eminent chairpersons to chair the session, Dr. Upma Saxena madam, Sampath Kumari ma'am, and Dr. Saijis Nair sir. Dr. Upma Saxena ma'am, we all know madam. Ma'am is currently governing council member, and ma'am has been on many prestigious positions and many awards to her credit. I welcome you, ma'am.
Thank you.
Sampath Kumari, madam, very eminent personality, and we all know madam. And ma'am has been, ma'am, she is president board of studies of Ob-Gyn, Tamil Nadu, Dr. MGR Medical University during 2015 to 19, and member board of studies Ob-Gyn, Meenakshi Medical University chairperson. Ma'am, you do not need any introduction. We all know you are very hardcore academician. I welcome you, ma'am. Ma'am is here. Yes, welcome, ma'am. And Dr. Saijis Nair, very academic and very active person. And Saijis, he is also currently ICOG Governing Council member and chairperson, Midlife Management Committee of FOGSI during 2021 to 24, and many awards to his credit. Welcome, Dr. Saijis. And now I hand over the session to our speakers. And I request if Dr. Upma ma'am is there. Upma ma'am, kindly. Yeah, kindly introduce.
So thanks, Dr. Kanchan. So at the outset, I want to thank Dr. Sheila Mane ma'am, Dr. Pratik, and the convener for today's program, Dr. Sita, Dr. Chinmay, my dear friend, and Dr. Kanchan. So it's my privilege to introduce the next speaker who needs no introduction, Dr. Chinmay Ratha. She has so many accolades to her kitty, and she is a very decorated speaker, and She's Director and Lead Consultant at Resolution Center of Fetal Medicine, Hyderabad. She's also President, SFM Telangana chapter. We all know she is ICOG Governing Council member. She was past FOGSI chairperson of FOGSI Perinatology Committee. She's also member Scientific Committee, IMA Telangana, and she also member AICC RCOG IRC South Zone Committee. So now floor is all yours, Dr. Chinmay, and she'll be talking about TIFA scan, a video presentation. So we all know the second trimester anomaly scan is very, very important, and she'll enlighten us more how to go the best way for doing it.
Thank you very much, Uma Madam. This is a great opportunity. I thank Dr. Sheila for helping us arrange such masterclasses where we are dealing with problems that we have on a day-to-day basis, and especially with ultrasound, there are some important messages to go in each trimester. So the first trimester was done so well. Now we have the responsibility of doing the second trimester ultrasound assessment. And one of the important landmarks here is the mid-trimester anomaly scan, which can be done anytime between 18 to 23 weeks. My only challenge is I have to finish the whole thing in 15 minutes because I can definitely not do that scan in 15 minutes, but speaking about it is even worse. So as Dr. Sita said, we follow some guidelines, and ICOG has given brilliant guidelines and very user-friendly guidelines. So I'm going to stick to this 20+2 planes approach for the second trimester scan, because that will tell us how simply we can have a checklist and finish the scan even if required in 15 minutes. But I'll try my best to do that. So before doing any scan, make sure you fill your PCP and DT forms. Do not ever forget that, because doctors get into trouble not because of doing bad scans, but because of keeping bad records. So this is the list of the 20+2 planes, which starts with a sweep of a longitudinal body of the head and for initial orientation, and then goes by plane 1, 2, 3, 4, just like you can see what is written in the screen. And this is not something which I have made myself. This is very easily available on the internet, free of cost. So you can take a picture or you can look at there. I'm not reading all these planes right now, but you will see that we will finish each plane one by one, and then finally finish with a transverse sweep of the body. So we start with a longitudinal sweep and we finish with a transverse sweep. So that is the video of the second trimester anomaly scan. So we are starting with a longitudinal view of the uterus, where you can see that you are looking at the placenta on the anterior wall. You're seeing a fetus lying in with the cephalic presentation. You can see a full bladder there. The heart is beating. So this is just an initial orientation. That is the first thing. So it's a longitudinal assessment of the uterine cavity in a gravid uterus. Then we go to, you can rule out anencephaly and you can rule out intrauterine fetal death, of course, if you see this thing correctly. Then the first plane. The first plane is a complete spine, including the sacrum with its covering and in the sagittal section of the spine. So this is a sagittal section, and you can see the railroad appearance of the spine very clearly from the cervical to the thoracic to the lumbar and then the sacral area. And you can see that the spine is complete with no breach in the skin on top of it. So what have we ruled out? Meningomyelocele, open spina bifida, sacral agenesis, sacrococcygeal teratomas. Plane 2 is again the complete spine, but the spine in the coronal section. So from sagittal, we have moved in another way. Coronal is like the way you look at yourself in the mirror. That is your coronal view. So from sagittal, you've moved coronal, and then you investigate the spine again at different dimensions. And as you can see, the difference from the sagittal section is you can see the middle of the body. You can also see the diameter of the spinal canal. So in case there are abnormal, dilatations of the spinal canal, you can see in this area. So open spina bifida, sacral agenesis can be ruled out. The third plane is similar to the first two planes, but it is in the coronal direction. So in the same coronal plane where we were looking at the coronal section of the spine, we go a little deeper and see the coronal body of the fetus. So when you see the coronal body, you're able to see both domes of the diaphragm, and you're able to make an assessment of the visceral arrangement. So you see the heart on the same side as you see the stomach. You look at the bladder. You sometimes are able to look at the kidneys. So that is a coronal assessment of the body of the fetus. And the advantage of this is if there are things like
situs inversus, renal agenesis, or CPAMS, echogenic bowel, lots of problems you may be, and any major lower urinary tract obstruction you may be able to see in this plane. Now, it was a coincidence. In fact, these videos I took to today only because you can see that is the advantage of doing the coronal section. That is a normal one, which you can see on the left side. And on the right side, if you see on the same coronal section, you are able to see that the stomach is in the thorax. And just by this coronal assessment, we were able to diagnose that this is a case of a congenital diaphragmatic hernia. Since I had to do the talk today, I saw this, so I just incorporated this video inside. But that is how powerful this scan is, that just by these simple planes, we are able to make diagnosis of almost more than 65 abnormalities. So spina bifida will be very different from the normal pictures that you just saw here. You will have huge abnormalities in the spinal contour, and you can see protrusions. And whenever you see protrusions in the spine, which indicate meningomyelocele, you will also be able to see changes in the fetal head. The shape of the head might become like a lemon. The shape of the cerebellum might become like a banana. And these are indirect signs of open neural tube defects. So the plane 1, 2, 3 will tell us about the spine and the coronal section of the body. Then comes plane 4. In plane 4, you look at the axial section of the fetal head. And here you're looking at the axial section of the fetal head along the ventricles, the cerebral ventricles. So this is called the transventricular plane. And if this is normal, you're ruling out lobar holoprosencephaly, absent corpus callosum, lemon-shaped skull, encephalocele, skeletal dysplasia, skin edemas, etc. So plane 5 is a little deeper than that, and you go from the ventricular plane into the transthalamic plane. So you can see the thalamus in between. There is a line called the falx cerebri, which divides the brain into left and the right side. And even the thalamus is not fused, but divided into the left and the right side. So this helps us ruling out a certain number of abnormalities as are written there in the box downstairs. Various CNS abnormalities can be ruled out because you see a good transthalamic plane. Then you have the transcerebellar plane, which is slightly more oblique than the thalamic plane, again in the axial section of the fetal head. Axial means transverse. So in the transverse section of the fetal head, you can see the cavum septum pellucidum anteriorly, and posteriorly you can see a dumbbell-shaped cerebellum. Behind that is the cisterna magna, and then there is a skin behind it. So in the screening of the central nervous system in mid-trimester, you look at the head shape, lateral ventricles, cavum septum pellucidum, the thalami, cerebellum, cisterna magna, and the spine. And if all that is normal, then it's very reassuring. There are clear-cut guidelines how to measure all this. For example, for the ventriculomegaly, Dr. Sita showed us this butterfly sign in the first trimester. And when the butterfly sign is replaced by fluid all over, you know that there is ventriculomegaly in first trimester. But in second trimester, you do an objective measurement of the ventricle. And if it is more than 10 mm along the long axis, perpendicular to the long axis of the ventricle, then you call it ventriculomegaly. So always measure that correctly, because ventriculomegaly itself is a sign of problems. And if there is ventriculomegaly, look at the spine, look at the midline structures of the brain. This is extending your regular checklist to look for corpus callosum, to look for other things in the brain, and then make a diagnosis. If you do not see ahead at all, then it is an anencephaly. Thankfully, in today's day and age, we don't get second trimester anencephalies, because first trimester scanning is becoming so much better that people are diagnosing this in the first trimester. So always look for the standard views, and whenever these are missing, suspect abnormality, and then escalate your scan to a higher level, so that not only can you detect the abnormality, but you can also demarcate where exactly things are going wrong. And abnormalities in each place, this is like an abnormality of not the brain per se, but of the skull. So this is because of unusual fusion of sutures in the skull before craniosynostosis. And therefore, when you do these three planes, the plane 4, 5, and 6, you are able to rule out so many problems. Then coming to plane 7, which is the 4-chamber view of the heart. So as you can see here in the axial section of the thorax, you can see the 4-chamber view of the fetal heart. And once you know to identify the chambers and the connections, you can do a yeoman service to the fetus by detecting all these abnormalities that have been given here. So in plane 7, if there is a problem in the thorax also, you will be able to see that. So the checklist for the heart is to see normally appearing chest and lungs, heart activity present, present, 4 chambers present in the normal position, the aortic and pulmonary tracts, which we will see in some time, and absence of an diaphragmatic hernia. So the cardiac situs can be determined. The easiest way to determine situs is to keep your right hand like this and imagine the baby in this position. The fist represents the head of the baby. The back of the hand represents the spine of the baby. If you keep your right hand like this and orient it along the fetus, then the thumb represents the left side. So then you identify the left side, make sure that the stomach and the heart are on the left side. So always you start the heart scan from the abdomen, look at the stomach and see that the apex of the heart is at the same side. Once you get the 4-chamber view, then you assess the cardiac axis and see that it is between the 22 and 65 degrees centigrade, the degrees of orientation. And the 4-chamber view has its specific requirements which have been given here on this scan. And you can see the 4-chamber view in 2 major orientations. We call that the plane 7A and 7B. One is the apical 4-chamber view where the apex is pointing up. The other one is the lateral 4-chamber view where you can see the interventricular septum very well. And then when you twist from the 4-chamber view, you are able to make out the outflow tracts. The left outflow tract will be an unbranched outflow tract, whereas the right outflow tract will be the pulmonary arteries. These are the pulmonary veins entering the left atrium, because abnormal pulmonary vein connection is also a common congenital abnormality, and that can be missed if we don't look at it very carefully. So looking at the outflow tracts, the right outflow tract, the left outflow tract, and the 3-vessel view is important. So for the left outflow tract from the 4-chamber view, you twist your probe, you rotate it towards the right shoulder, and then you see the aorta opening up there, and then you can go ahead and trace the left ventricular outflow tract. Here, if that is abnormal, you will find out aortic stenosis, overriding of the aorta, TGA, or moderate VSDs. Then you come to the right outflow tract, and here you again rotate your probe 90 degrees from where the left outflow tract is, and you get the pulmonary artery. You can see the branching of the pulmonary artery, and you see the directions and the width and the diameter of these vessels. Then you have if you have abnormality, you will look at pulmonary atresia, stenosis, or even transposition of the great vessels. In plane 10, you look at the 3-vessel trachea view, where you look at the pulmonary artery, the aorta, and the superior vena cava in a particular order. And when you try to form a V there, the V goes towards the left side of the trachea, showing us that this is a left aortic arch. Whenever Dr. Sita had shown us a picture of a right-sided aortic arch, and all these can be detected when you look at the 3-vessel trachea view. So this can be augmented by using colors. So the use of the color has now been brought into the new guidelines because most machines do have color. So why not use color and see the direction of blood flow? Red and blue are the directions of blood flow. Everything flowing towards the probe is red and away from the probe is blue. So you can make out the direction of blood flow. So whenever the stomach is in one direction and the heart is in another direction, you have to worry whether it is a dextrocardia or a levocardia with the dextrogastria, because these can be indications of heterotaxy syndromes. So the planes of the heart are very well defined, and once you have followed these planes, at least 80 to 90% of major cardiac abnormalities have been ruled out. In the same plane, you're also looking at the lungs in plane 7. So the lungs look like homogeneous structures by both sides of the heart, and if there are abnormalities like these big cysts or echogenic masses in the lung like CPAMs or major cystic conditions in the thorax, they will be known. If there is fluid outside the lung, it will be pleural effusion. Again, you have to look at the etiology, and that opens up a Pandora's box. When the lungs are deviated to a side because of another extrathoracic structure inside like the stomach, this is diaphragmatic hernia, and that needs a lot of workup thereafter. Then you come to plane 11, which is the transverse section of the stomach, showing the stomach bubble and the umbilical vein, which is moving away from the stomach. So you look at this plane and you rule out abdominal situs inversus, you see the rule out any ascites, duodenal atresia, esophageal atresia without fistula. Even open spina bifida can be seen here if you see a protrusion to the back of the stomach, and therefore this is also a very powerful plane. Then in plane 12, you go down a little below the previous plane and look at the cord insertion. So that is the umbilical cord insertion, and once you have seen that, you've ruled out arthroscasis, omphalocele, and all major problems there. The abdomen checklist includes presence of the stomach in its routine position, no dilatation of bowels, and ability to see the kidneys and the cord insertion. So when we see a normal abdominal measurement picture, we have ruled out these abdominal wall hernias and any kind of bowel dilatations or exomphalos. And this is like duodenal atresia there. This is also a very common association with Down syndrome. So we need to work up for that. Echogenic bowel, dilated bowel loops, these are all problems. Then you have the transverse section of the fetal kidneys where you go lower down and you can see the kidneys by the sides of the plane, sides of the spine, that is the plane number 13. Then coming to plane number 14, these are abnormalities in the kidneys. Coming to plane number 14, that is a transverse section on the pelvis where you can see the umbilical cord starting there. So two umbilical arteries presenting as 3-vessel umbilical cord. When you have a single umbilical artery, you can see only one vessel by the sides of the bladder. So that is a single umbilical artery, which again necessitates very detailed anomaly assessment. The femoral diaphysis is important because skeletal dysplasias will present as short and abnormal bones. All 3 segments of all 4 limbs have to be checked again in the second trimester as was told in the first trimester. So the legs need to be followed right till the end there, and the orientation of the feet to the legs need to be seen. Similarly, you do the same for the hands. Any skeletal dysplasia will be very obvious, as can be seen in the slide here. Club feet can be seen with abnormal orientation of the feet, and the upper limbs can be seen clearly when you can look at the hands. You can see the fingers, you can even see the phalanges at that stage. Then plane 17 again is the hands, of course, arm, forearm, and the hand as such. So these are the planes for the positions that I told you now. In the face, we have to see the midline, fusion or the orbits, the palate there, and the coronal section of the lips and the nose, so that you rule out cleft lip and palate. We've come to plane 18 already in our 20 planes. Plane 19 is both the orbits and the lenses here. You can see the orbits, you can see the lenses inside, so you've ruled out aphakia or anophthalmia. Plane 20 is the median facial profile, again a very powerful plane where you can see the nasal bone, you can see the forehead, upper jaw and lower jaw. So we finished the 20 planes of the anomaly scan in my 15 minutes, and this of course rules out all these problems that we see here. Before we finish, we do a transverse sweep from the top to the bottom, where again, in case we've missed anything, we will get an idea. So we started with a longitudinal sweep and we finished with a transverse sweep, 1 vertebra at a time. So as I am sure you will understand that it is not easy to get all these in the time. So it needs a lot of practice. It needs a lot of, training. And when will you know that you've completed your scan? You just follow the checklist and tick off one after the other, everything. A well-conducted scan gives you a very, structured approach to diagnose fetal anomalies, but patients don't expect anomalies. So please don't start scans as a PR exercise. I see a lot of Instagram videos and, WhatsApp messages about good pictures and all. Let's be a little humble about it, because 65 abnormalities can be ruled out, but we know there are more than 65 abnormalities that exist in fetal medicine, and therefore just one scan cannot rule out everything. So deal with it with a little bit of humility. This is the list of abnormalities that you can rule out if you do a good second trimester scan. So our role is to distinguish between normal and abnormal, and once an abnormality is confirmed, it needs a whole range of workup. That is what the ICOG says. So while doing a fetal anomaly scan, we can't cure everything, but we certainly can care for everything. So the same principle remains while doing scans: do no harm. Thank you very much for a very patient hearing.
Dr. Upma, you're muted. Thank you very much, Dr. Chinmay. Brilliant videos, and for a crash course in the TPA scan. I've always said you are a fantastic asset to both FOGSI and ICOG. And also thank you for being one of the conveners for our fetal medicine course, which we run regularly.
So I just want to add, she just done full justice to ICOG paper 2025, finishing all the planes in 15 minutes. Hats off to you. It was a humongous task. You did it very well. So all revised. 15. Thanks a lot.
Thank you, Chinmay ma'am, for this wonderful talk. And now we can move to the next talk. And I request Dr. Saijas. Is Dr. Saijas there?
Dr. Sampath is there. Dr. Sampath is there.
I request Sampath ma'am to kindly introduce our next speaker available.
Sampath Kumari.
Yes, madam. Good evening, madam. Thanks for the opportunity to Sheila, madam, and Pratik for giving me an opportunity. Now you had the wonderful talk by the first trimester and the second trimester. Now Dr. Bella is there. Bella is the consultant of Bella's Women Hospital and Fetal Medicine Center, Mumbai, and she is the vice president elect and chairperson of FOGSI Imaging Committee. And a lot of credits for her. She is running the certified sonologist for fetal medicine, FOGSI ICOG certified trainer, author of many books, and the secretary of Association of Fellow Gynecologists Mumbai, and managing council member is part. And she has many awards to her credit. CN Don Award, FOGSI has Talent Award, and of all this, she is a wonderful sonologist and wonderful dancer. Still, we remember her dance everywhere. Dr. Bella, now the stage is yours. You can take up.
Thank you so much, Sampath Kumari ma'am, for those very kind words of introduction. And while I'm sharing my presentation, I would like to thank Dr. Sheila Mane madam, Dr. Pratik Tambe. I'll just share my presentation. Hope this is seen now.
Yes, okay. I forgot to thank Dr. Sadhana. Sadhana madam is also there, vice chair.
Yes.
Bella.
So, Dr. Sheila Mane, Dr. Pratik Tambe, Dr. Sadhana ma'am, Dr. Bhaskar Pal, President FOGSI, and the conveners, Dr. Sita Pal, and my friends, Dr. Sita, Dr. Chinmay, and Dr. Kanchan Prasad, for giving me this opportunity to be part of this wonderful fetal medicine webinar. Now, without much ado, because we have 15 minutes time, I would start with my topic, that is diagnosis of fetal growth restriction and monitoring. Again, a very, very vast subject, but I'll quickly try to highlight the important points. Now, we all know that fetal growth restriction is failure of fetus to reach its genetically determined growth potential. And from high resource to low resource setting, the incidence is from 3 to 30%. And we encounter this every day in our practice. And that's the reason we need to know everything about diagnosis as well as management of fetal growth restriction. Now, before we start about discussing the diagnosis, we must know there is only one classification which is important from diagnosis and management point of view, and that is early onset and late onset fetal growth restriction. Early onset is the one which develops before 32 weeks of pregnancy and is the one in which you find severe placental insufficiency and therefore all your abnormal Dopplers. Whereas late onset fetal growth restriction is the one which develops after 32 weeks of pregnancy and has mild placental insufficiency and lesser Doppler changes. So quickly we'll go through how to diagnose this. Now remember one thing, for diagnosis of fetal growth restriction, the proper diagnosis is key to management, and for that we need to understand certain concepts. The first and the important concept is small for gestational age. That is when the growth is less than 10 centile. And how do I diagnose small for gestational age? Well, for that, yes, number one is your correct last menstrual period. But condition applies here. The cycles have to be regular for us to take LMP for dating of pregnancy. And we can err. These days we know because of obesity, PCOD, the cycles are irregular, long, some patients have short cycle. So wrongly, we'll have the EDD, which is at either 37 weeks or at 42 or 43 weeks, which is going to be completely wrong. So it's very, very important that we assign the EDD early on in the pregnancy and fix the EDD and then look at the growth based on that. So if the LMP is not correct, patient doesn't remember, or if the cycles are irregular, which happens in 30 to 40% patients, what do? Well, we have ultrasound to help us, and proper CRL can help us. So from 7 to 10 weeks also, if the fetus is erect, we can get a good CRL, and then we can take this CRL for dating. But remember, you have to have a look at the image, and only if the CRL has been taken properly, we can take this CRL for dating. And of course, we know nuchal scan is gold standard for getting the dating or the EDD at 11 to 13 weeks scan. And we all know the importance of this particular image. So please, friends, whenever you date a pregnancy, whether at nuchal scan or between 8 to 10 weeks, always have a habit of looking at the images, and only if you have perfect images of CRL, please take that for dating. And then we do not change the EDD. Once it is assigned, we do not change the EDD in subsequent scans. So dating of pregnancy early in the pregnancy makes the foundation for entire monitoring of your pregnancy, whether it's for fetal growth restriction, whether it's for aneuploidy screening, whether it's for preterm or deciding the date for delivery. We need precise dating. So this foundation has to be perfect for your proper monitoring of pregnancy. Now comes the question, how do I diagnose fetal growth restriction? So, well, we should know based on the centiles that this is small for gestational age, that is less than 10 centile, but not all are FGR. 70% of these small fetuses are normal small or constitutionally small. 10% could be abnormal small because of chromosomal problems, structural defects, or infection, and 20% are growth restricted because of uteroplacental insufficiency, about which I'm going to talk a bit in detail today. So, we always, when we take the history, we look at the maternal paternal size. Sometimes short stature mother or father or both can influence the size of baby. We have to rule out structural anomaly, chromosomal anomaly, markers of infection on ultrasound. And then once we have ruled out all this, then we go on and have a look at the growth charts and the Dopplers to try and diagnose fetal growth restriction. So what is important in growth monitoring is centiles and growth charts. So in growth charts, we look at the mainly abdominal circumference in weight, and you can find out, we look at the growth chart and growth trajectory. So here you can see that in early onset fetal growth restriction, the growth of the fetus is falling below the 10 centile before 32 weeks of pregnancy, whereas in late onset fetal growth restriction, you can see the same happening after 32 weeks of pregnancy. So that's the first thing we look at. And it is very important to look at the growth scan, because both it is easier for us to explain to the patient, as well as it is easier for the obstetrician to understand whether the fetus is growing on the same centile or it is falling. Once we have seen that the growth has fallen below 10 centile, then it's our duty to have a look at the Dopplers. We have already ruled out the structural defects and the chromosomal markers. Now we look at the multi-vessel Doppler, that's uterine artery, umbilical artery, middle cerebral artery, and also ductus venosus later on. So, uterine artery, we know that as pregnancy advances, the diastolic flow increases, and therefore the PI of uterine artery falls. Now, what is the role of a uterine artery in diagnosis? Well, of course, it has a very, very major role. The mean uterine artery, more than 95th centile, has a major role in prediction of fetal growth restriction, but the same has also role in diagnosis and management of fetal growth restriction. We'll see in the upcoming chart for the same. The other vessel we look at is the umbilical artery Doppler, which is normally, this is the typical normal waveform with a good diastolic flow. But when the umbilical artery PI is more than 95th centile, it tells us that 30% of placenta is damaged. When there is absent end diastolic flow, it tells us 50% of placenta is damaged. And when there is reversal of diastolic flow, it tells us 70% of placenta is damaged. So just by looking at the waveform, we can make out how much of the placenta is affected. So please, friends, have a look at the images of umbilical artery as well. And it is a very good predictor for early onset fetal growth restriction, because more than 30% of placenta is damaged, but not for the late onset FGR, because here the damage is less than 30% in the placenta. Next vessel comes is the middle cerebral artery, and reduced middle cerebral artery PI, normally it is high. When it is less than 5th centile, it tells us about the brain sparing effect. Now, what is brain sparing effect? We know that a growth restricted fetus will try to send more blood to the vital organs, that's the heart, brain, adrenals. And in the brain, we can very well make out based on the middle cerebral artery. But as far as middle cerebral artery is concerned, more sensitive is the cerebroplacental ratio, that is MCA-PI upon umbilical artery PI. And when CPR is less than 5th centile, it tells us there is chronic hypoxia and the fetus is trying to compensate for the same. Now, the interpretation of CPR less than 5th centile is different in early versus late FGR. In early onset FGR, it tells us that fetus is able to cope and it is not a trigger for delivery. Whereas in late FGR, it raises a red flag and tells you have to now look at the kick count, the CTG, the NSG, the BPP, and decide when to take out the baby. The last vessel is the ductus venosus. It's a very, very important vessel because it's like it's a vessel which is equal to jugular vein in adult. It is usually triphasic, and in this, the tiny A wave is what is very, very important, which has to be positive, right, for it to be normal. Whenever there is absent or reversal of A wave, that tells you that now there is acidosis which is set in, and therefore, at any stage, beyond the age of viability, beyond 24 weeks, if you find in a growth restricted fetus a reversal of A wave, we have to deliver the baby because otherwise there will be death within few hours. So this vessel is a trigger for delivery. Now, having looked at the basics of Dopplers, now comes the Delphi consensus that we use to diagnose early and late FGR. And in early FGR, in both the early and late, if the AC or FW is less than 3rd centile, even without abnormal Dopplers, it is FGR. But in early FGR, if the AC or FW is less than 10th centile, with either uterine or umbilical artery, PI more than 95th centile, it's early FGR. Whereas in late FGR, ACFW less than 10th centile, or ACFW crossing 2 quartiles, that is 50 centiles, is also a marker for late FGR. And of course, CPR less than 5th centile or uterine artery PI more than 95th centile. After this comes, we have diagnosed. How do we monitor? So again, for monitoring in-fetal growth restriction because of placental insufficiency, we need Dopplers. And this is Barcelona staging, which precisely tells you whether to monitor with Dopplers weekly, bi-weekly, twice every alternate day, or deliver based on these Dopplers. Of course, because of paucity of time, I'll not be able to go into details, but it is the umbilical artery and ductus venosus in early FGR which will tell you how to monitor, how frequently to monitor, and when to deliver. Now, in late FGR, that is more than 32 weeks, we have repeatedly heard that the placental damage is mild, that is less than 30%. Does that mean that it needs less monitoring or less intense monitoring? No, in fact, it needs closer monitoring because these close to term fetuses have reduced tolerance to hypoxia, and therefore there can be sudden stillbirth. Here your Dopplers will not be abnormal, so you will not know when to deliver if you are not looking at your CTG, at your kick count, at your NSG, and deciding when to deliver. And these are responsible for 40% of late stillbirths in FGR. So it's very important to monitor this. And how do we monitor? Now the Doppler is not going to help because I know that my umbilicals and ductors will be absolutely normal, but there can be fetal death next day. So I'll have to keep counsel my patient about kick count well, CTG, NSG, and BPP is going to help me to decide when to deliver these babies, which is out of the scope for this talk. So it is extremely important for us to correctly diagnose small for gestational age with the help of dating scan or correct LMP, differentiate small for gestational age from fetal growth restriction based on your Dopplers, ascertain the cause of fetal growth restriction, as that will decide the line of management. And of course, when there is placental cause, as in early onset fetal growth restriction, Doppler will help. Whereas in cases of late onset fetal growth restriction. The other parameters which are for the brainstem, like the kick count, the CTG, the BPP, and NST, are going to help us decide when to take out the baby. But well, the most important thing is we must be sensitized enough to make the good use of ultrasound and Dopplers in all our patients, and then we'll be able to help almost each and every patient with fetal growth restriction, be it early onset or late onset fetal growth restriction. With this, I would like to conclude my talk. I have finished 40 seconds earlier. Thank you so much for patient hearing. Thank you.
Thank you, Dr. Bella, for finishing 40 seconds earlier and telling all the early and late crisp in within the 15 minutes.
Thank you.
Anyway, hope it will be useful for all the listeners. I think more than 445 listeners are there. Thank you, Dr. Bella. We'll go with the next speaker, I think. If any questions in the chat box,
this
please
talk
answer.
is very important, Bella. If we have to prevent the stillbirth, we have to, I already earlier also I said to her. So
Yes,
it is
yes.
better we go on giving the information to people that they have to diagnose. I mean, sometimes late FGR is not diagnosed and then those mishaps happen. Yeah,
True,
thank you.
true. Thank
And
you so
thank you,
much.
Dr.
Bella,
Sanjay
answer
Kumari, for
Yes,
gracing the
madam. Thank you
occasion.
so much.
There are
Bella,
some
answer the questions in the
institutions.
chat box.
Sure,
There are
ma'am.
some institutions where they still don't do a third trimester ultrasound scan to go into the interiors.
Yeah.
That is how even these patients who land up with late FGR and sudden IUFD are missed. So that is why this talk is so important.
And one growth scan with Doppler at 32 to 36 weeks is extremely important to be able to pick up these late FGRs. Yeah, thank you so much.
Thank you. Thank you so much, Bella ma'am, for this excellent talk. And now I request Upma ma'am to kindly introduce our next speaker. And meanwhile, I request all the speakers to answer the queries of audience in the chat box.
So it's my privilege now to introduce Dr. Kushagriji Ghosh, sir, and he's the most gentle person I have ever seen, and he's a master in doing scanning. And he's director, Institute of Fetal Medicine, Kolkata, and he's also consultant OBGY, Woodland and Neotia Hospital, Kolkata, and also MD examiners, and he has many laurels to his kitty. So Dr. Ghosh will be taking up the next talk on
Ultrasound and
ultrasound in multiple pregnancy. What's different?
Sir, we can't see your video for some reason. I think your webcam is not functioning.
Right. Thank you. Thank you very much. Thank you for inviting me for this very, very important ICOG initiative. Unfortunately, my video is not working. I don't think you'll be able to see my face, but I hope you can hear me. Can you hear me?
Yeah,
yes,
we are able to hear you.
So we will carry on. Yeah.
Dr. Ghosh.
Somehow, why it has not happening, I don't know. But today we are going to talk about ultrasound in multiple pregnancy. What's different? Now, when we talk about ultrasound in twin pregnancy, starts from determination of gestational age, how it's different, chorionicity, labeling, timing, and frequency.
Dr. Ghosh, we are not able to see your PPT. We are not able to see your PPT.
You are not able to see your PPT. Okay,
no,
sorry.
No. Just reshare
I
a
think
second.
I have shared it. Wait. Let me share. How I shared it.
You have to minimize it. You have to minimize it. And then when you share, you will see it and then click on it twice.
You have to minimize. Okay.
Yeah, you have to open it and then minimize it.
Okay, minimize. Now I'm sharing.
Now go to the share button and you should be able to see your PPT now. Then you click on it when you see it. Yeah, now we can see it.
Now? Oh,
yeah. Just make it full
yes,
screen, Dr. Ghosh.
Yes, I'll make it full. Okay, can you see now?
Yeah.
Okay, thank you.
Absolutely fine
So
now.
let me start from the beginning. It's ultrasound in multiple pregnancy. What's different? Now, when we talk about ultrasound in multiple pregnancy, starts from determination of gestational age, chorionicity, labeling of twins, multiple pregnancy, timing and frequency of ultrasound depends on the chorionicity, screening for aneuploidies and structural anomalies, specific issues like single fetal demise or discordancy of different sorts. Then there are complications unique to multiple pregnancy and higher order multiple births. So there is a huge topic. The syllabus is vast. And let us see how much we can cover and do justice to the topic as well. Now, let us start with dating of twin pregnancy. We know that CRL is the most accurate measurement of gestational age. So for singleton, it's fine. But what happens in twin pregnancy? In the ideal time for dating should be earlier than 13 weeks. And between 11 and 14 weeks, the CRL of the larger twin is used. But there are, of course, some studies which have used the smaller twin, but by and large, majority of the fetal medicine specialists would use CRL of the larger twin. Above 14 weeks, the head circumference of the larger twin is used. And all these things are superseded in ART pregnancy, where we use the embryo transfer date or the blastocyst transfer date as the date of conception, +2 days or +5 days. Now, coming to determination of chorionicity, this is probably the most important management in the step in the management of multiple pregnancy. And we all know the determination of chorionicity is done best between 11 and 14 weeks by the T sign, which is monochorionic, and the lambda sign, which is dichorionic. And in monochorionic pregnancy twins, we sometimes have the black lambda. But beyond 14 weeks, what happens? The chorion levy sometimes fuses with the amnion, and therefore there is only 80 to 90% accuracy. So beyond 14 weeks, it is not so accurate. Now let us come to labeling of twins. And this labeling of twins is based on as many parameters as possible. Like first of all, we describe the upper, lower, right, left, depending on the placental location, cord insertion from the placental edge, like marginal or central insertion of the cord, fetal sex. Just in code, we write discordant size, discordant anomaly. That's how we label as A or B. And membrane insertion. Close to the, by convention, the twin, the membrane, which is close to the cervix, is usually called twin A. And in multiple pregnancy, from then on, we go anti-clockwise. So it's not that there is a very sacrosanct way of labeling twins, and therefore descriptive way of labeling is more important than mentioning it as A or B. Because if we mention as A and B, then the next person who is scanning some other center will really not know which one was A and which one was B. So basically we go by description, like for example, twin A on the maternal right, with posterior placenta, with marginal insertion of cord. So that sort of description should be there. And we have to be consistent with the same nomenclature. Now let us come to ultrasound monitoring schedule in uncomplicated twins. In uncomplicated twins, the monitoring schedule depends on the chorionicity. In dichorionic pregnancy, we first do the scan between 11 and 14 weeks. Sometimes we keep on doing scans before that. Anomaly scan, and then every 4 weeks thereafter. But in monochorionic pregnancy, beyond 16 weeks, the recommendation is to go for 2 weekly scans. So a monochorionic twin would have a number of scans during pregnancy. And in complicated twins, the frequency is more increased. So if you go by the schedule, which was published first by Asma Khalil Group, the first scan, the proper scan between 11 and 14 weeks, we do the dating, labeling, chorionicity, and screening. And between 20 to 22 weeks, go for the detailed anatomy scan, amniotic fluid volume, cervical length, and then after 24 weeks, 28 weeks, 32 weeks, 36 weeks, etc., we do scanning every 4 weeks for fetal growth and Doppler and amniotic fluid volume. In monochorionic pregnancy, the initial stages are almost the same, except for the fact from 16 weeks onwards, we keep on doing scans for fetal growth. And the detailed anomaly scan is done as usual, but we always introduce Doppler at the 20-week scan, cervical length and discordance we try to estimate. And from then on, we try to measure, as in dichorionic pregnancy, fetal growth, deepest vertical pool, and Doppler measurements. Now, what is the optimum time for delivery of uncomplicated twins? If twins go completely uncomplicated, then how long should we continue? The recommendation usually is that for dichorionic pregnancy, we try to deliver between 37 and 38 weeks. And in monochorionic pregnancy, we try to deliver between 36 and 37 weeks, because after that, the perinatal morbidity rises slightly. Now, regarding screening of aneuploidy in twins is a vast topic, but to summarize in 2 slides, actually, you might have seen that I'm actually using 2 or 3 slides per topic. Screening for aneuploidy in twins, the best is NIPS, and the sensitivity is slightly lower than singleton, but still it is the best. And FTS, or the combined screening, is the second best. In dichorionic twins, the fetuses have different risks, and the risks are based on individual CRL and the NT measurements. And therefore, we call that aneuploidy screening in dichorionic pregnancies fetus specific, which means we get a risk of one risk in fetus A and the other risk in fetus B. In monochorionic pregnancy, both fetuses have the same risk, and therefore we call it not fetus specific, but pregnancy specific. Why? Because it is based on average CRL and average NT. So both the fetuses get the same risk. Now, aneuploidy screening in vanishing twin is one of the very perplexing things. The definition of a vanishing twin is an empty gestation sac or a dead embryo in one of the sacs. And the incidence is almost up to 20%, more than what we think. And in FTS, the PAPE is higher compared to singleton. And therefore, there is a chance of missing Down syndrome, because we know in Down syndrome what happens, the PAPE goes down. In NIPS, on the other hand, there is a higher false positive rate. So which means there might be a slight chance of doing more amnios if we do NIPS in vanishing twins. And therefore, some people do NIPS, but majority of us would probably be confining to ourselves to doing using maternal age, CRL, and NT for measurement. So there is a difference of opinion there. Now, regarding early anatomy in twins between 11 and 14 weeks, we can see a discordant CRL. We can even see a discordant NT or a discordant ductus venosus Doppler. The incidence of CRL discordance is around 20%, NT discordance is around 20%, 10%, 20%, and reversed A wave discordancy. And I mean, one of the twins has a A wave reversal, that is also possible. And it has been noted that if there is discordancy at such an early pregnancy, then there is a higher chance of TTTS, single IUD, SFGR, and discordant anomaly later on during pregnancy, though the predictability of any of these 3 signs is quite poor, 30 to 40%. So we really can't do any action based on this, but we have to follow the patients. Now, when we do have a discordant anomaly, what do we mean? It usually means that one fetus is normal and the other fetus is anomalous. And in that case, what do? We have 3 options basically. One is to continue pregnancy with one abnormal baby. One is to do an MTP, termination of the whole pregnancy, and the other will be feticide, selective feticide. So for this, a lot of counseling needs to be done. Now, if it is a dichorionic pregnancy, fetal reduction is used using agents like air, lignocaine, and potassium chloride intracardiac. The majority of the people would be using potassium chloride because there are pros and cons of using those. Now, this is a fetal reduction being done with KCL in a case of omphalocele, which you can see in the twin pregnancy, which you can see in the screen. And after getting the KCL, the needle is being taken out. And this is possible in DCDA pregnancy. And this is another patient, for example, where fetal reduction is being done in an ectopia cordis in a dichorionic diamniotic pregnancy. So that is what it is done. Now, when we have discordant fetal anomaly in a case of monochorionic twin, then it is possible. For example, here we see a monochorionic twin with one fetus anencephaly. Here, one of the fetuses has VSD, the other fetus is normal. Here, one fetus is hydropic, the other one is normal. These are all possible in monochorionic pregnancy. So some people have an idea in monochorionic pregnancy, if there is a problem in one, the other will also have a problem. It is not like that always. So in MC2H, for example, we have 2 vessel cord in one and 3 vessel cord in the other. So all sorts of combinations are possible. And in MC twins, if the couple do decide for fetal reduction in one of the twins, if they want to continue pregnancy with one good baby, then the fetal reduction cannot be performed with intracardiac KCL like DCDF pregnancy because of anastomosis in the placenta. And therefore, selective feticide has to be done in monochorionic pregnancy either by intrafetal laser ablation or radio frequency ablation or bipolar cord occlusion or microwave ablation. Now, this is a laser ablation being done. It is either done by ND-YAG or diode laser with 400 MCM wavelength in short bursts, or it is done by radio frequency ablation. And it is a little challenging, but it can be done with a little bit of expertise. And then this is a radio frequency monitor we see, and that is how it is being done with the specific needle. And this is a microwave ablation because these days we have stopped doing radio frequency ablation and switched over to microwave. And there are pros and cons of doing it. And then let us come to the next one, which is called fetal growth restriction in twins. The first question that comes to our mind is which chart to use. Single charts would obviously overdiagnose FGR. That is because single babies are slightly bigger than twin babies. And of course, then there will be more chance of intervention, which means early delivery and prematurity. On the other hand, if we use twin-specific chart, we underdiagnose FGR, and there are consequences of undiagnosed FGR like stillbirth and asphyxia. So the consensus is that we use a standard singleton chart in twin pregnancy with the premise that we probably overdiagnose FGR, but that is something which will increase our monitoring, and close monitoring is something which is worth doing rather than missing FGR. And the standard headlock chart is used where HC, AC, FL, and BPD are used. Now, there was no clear guideline regarding diagnosis of FGR in twin pregnancy previously, and therefore, the world bodies, experts sat together and came out with a Delphi consensus. Whenever there is a Delphi consensus, we know there is no consensus. That's why a lot of people sit together and try to form a consensus. And if one of the twin is less than a third centile, then immediately it is diagnosed as FGR, like in case of singleton. An additional criteria is required when it is between third and 10th centile, then we need one more criteria. Now here there is a little difference between diagnosis. I'm giving you the Delphi consensus only. I know there are other views also. So here the DC twins, 2 out of 3 criteria has to be fulfilled before we can call it a FGR. Estimated fetal weight of one twin should be less than 10 centile. Estimated fetal weight discordance of more than 25% or ambulatory PI of smaller twin more than 95th centile. Any 2 out of these 3 present would be called as an FGR. In MC twins, we have 2 out of 4, and these are the 4 criteria. This is by Khalil et al. In 2019. We are still following that. Estimated fetal weight of one twin less than 10 centile, AC of one twin less than 10 centile, or EFW discordance of more than 25th centile, or ambulatory PI of smaller twin more than 95th centile. I don't expect that the students should remember everything, but at least they should have the chart handy. That is what it is. But one thing it is very important for us to understand what do we mean by discordant growth in twins. Whenever there's an inter-twin discordancy of more than 25%, then we call it a discordant growth twin. But recent articles are coming up that probably 25% is the one which is too late, and probably we should be taking as 20%. But as of now, it is 25%. And how do we calculate it? By the difference between the larger and the smaller twin divided by the larger twin into 100. And if it comes to 25% or more, we call it discordant growth. And if both twins are less than 10 centile, in most cases, it will be classified as small for gestational age rather than FGR. And the management would be follow-up ultrasonography and delivery. It is very difficult to go through the whole gamut of HCR in twins in this short span of time. With the next important article is the topic is single fetal demise. This is another very important topic in twins, and we know the commonest problem that happens with single fetal demise, irrespective of whether dichorionic or monochorionic, is preterm birth less than 34 weeks. Now, apart from that, the monochorionic pregnancies have two specific complications. One, compared to dichorionic. One is the death of the co-twin, which is quite high in monochorionic compared to dichorionic, and neuro impairment and abnormal neonatal brain imaging in the surviving twin in monochorionic compared to dichorionic pregnancy. The complications are higher. So what happens in single fetal demise in MC twins? The effect of single fetal demise on surviving twin in MC twins could be immediate. And the immediate is one because of acute exsanguination of the surviving fetus into bleeding into the dead fetus. And therefore, suddenly they go into hypoxia and they die. And if they don't die, if the fetus is continuing the fetal heartbeat, then there could be delayed vascular injury and end organ damage. And that is because of placental communication, vascular communications through the placenta, arterial anastomosis mostly, venous anastomosis mostly, which is not usually due to AV anastomosis also, AV anastomosis. So acute exsanguination theory can explain most prenatal and postnatal findings in the surviving fetus. Like, for example,
Apologies for interrupting. You've exceeded your time, sir.
Okay, fine. Then I think we have to stop it there. We can't carry on because the topic is very huge, actually.
Thanks a lot, Dr. Ghosh, for beautifully
Yes.
highlighting that in twins is very important. You made it very clear to everyone that the chorionicity is very, very important, and it is criminal if the radiologist who is scanning in 11 to 14 weeks doesn't comment about the chorionicity, because all the management, as you have shown, depends on whether it's a monochorionic twin or a dichorionic twin. And I just want to add, you said about the preterm labor when the one twin device, but we should not cause iatrogenic prematurity in both monochorionic and dichorionic because the damage is already done. So we should not intervene, leading to preterm iatrogenic prematurity. Thanks a lot, Dr. Ghosh.
Thank you very much. Thank you very much.
Thank you to the speakers of the second session. Fantastic evidence-based talks. Unfortunately, we ran out of time for that third talk, and there were so many other concepts which could have been explored. Thank you very much to the chairpersons as well as to the speakers of this session, Dr. Chinmay, Dr. Bela, and Dr. Prashad. Can we proceed with the next session, please?
Thank you, Dr. Ghosh, for accepting our invitation.
Thank you, sir. Now I hand over the session to Chinmay Ratha, ma'am.
Thank you, Dr. Kanchan, and it's been a great going so far. We are now for the third session of this program, and we have with us some stalwart chairpersons. It's a privilege to invite Professor Narendra Malhotra as one of the chairs of this session. Sir, are you here? And Dr. Malhotra really needs no introduction to any congregation of obstetricians and gynecologists, and more so in the setting of ultrasound. He's been one of the, foremost people taking the flag of obstetric ultrasound, not only in India, but also worldwide. Sir has been a past president of FOGSI and has held so many leadership positions all over the world that, just reading his CV is a kind of inspiration for all of us. Thank you, sir. Thank you. I can't see you, but your voice itself is such a big, inspiration for all of us. We also have with us Meeta ma'am, Dr. Meeta Singh, who is from our very own Hyderabad. And Meeta ma'am is another person who does a lot of Ob-Gyn ultrasound. And she runs a training center also for ultrasound in training from the ICOG. She's the director and consultant of obstetrics and gynecology and with special interest in menopause physiology at Tanveer Hospital Hospital in Hyderabad. Her areas of interest are obstetrics, menopause, postmenopausal osteoporosis. They run a very good, DEXA clinic there, PCOS and or PMOS now, and gynae ultrasonography. Welcome, madam. She holds a lot of positions in many academic bodies. We also have with us Professor Uma Pandey from BHU, and she is a professor in the Department of OB-GYN at IMS BHU, and she holds a fellowship from the Royal College of Obstetrics and Gynecology, London, an examiner for the MRCOG exams, one of our co-members in the ICOG Governing Council. So welcome, Dr. Uma, and with this, I hand over the proceedings to the chairpersons.
Very good evening to all of you. Apologies, I'll be coming in first because I have some guests, so I may be in and out of the seminar. So let me just introduce this ICOG training master classes on all topics practically. And today we have just heard a fantastic 6 lectures on OB, obstetrics ultrasound, which have been an eye-opener even to me, and the lovely videos, Chinmaya, and because I'm going to ask you for those videos for the FOGSI newsletter where they go, which you've already contributed one to it. Anyway, we are now at the third session, and this is in gynecology and infertility, and which is equally important as obstetrics, especially follicle monitoring, which is very, very important for a gynec or an infertility specialist to do himself or herself. We cannot depend on the radiologist scanning the follicle and telling us and then deciding the doses, because that is not. And we have Parsuram Gopinath for it, young, budding, great, now already budded, not expert in ART. Then we have Dr. S. Suresh, our champion, telling us about the interventional procedures, ultrasound guided, especially embryo reduction, CVS, and amniocentesis. And of course, the uterine anomalies and the tubal assessment, which is very, very important part of an infertility scan, is going to be taken third. Without wasting any time, I invite the first speaker, Parsuram Gopinath, and the other chairpersons will conclude and invite the questions. Parsuram, all yours.
Thank you, sir. I'll just share my PPT.
Thank you, Dr. Narendra, for joining in your busy schedule. Thank you.
Good evening, one and all, respected chairperson, secretary, and other dignitaries of ICOG, and it's a pleasure to be here. So, from the whole obstetric realm, probably I'm going to take you through a different aspects of ultrasound where we're using it in gynecology, primarily in fertility. So, have you ever thought at some point of time as to why is ovulation reduction? What makes ovulation reduction successful? So, from whatever techniques or whatever procedures that we do, my understanding is that one of the key factors of making an ovulation induction successful, or an IUI with ovulation induction successful, is primarily making sure that you have an ovulation that is happening, especially in a patient who's anovulatory or oligoovulatory, or you want a slightly a multifollicular development in somebody who's actually having ovulation, and getting the timing right. So these two become a very integral part of making sure your ovulation induction or ovulation induction with IUI is successful. Hence, follicular monitoring becomes an integral part here. Now, when we actually look at the key elements in follicular monitoring, I think there are several things that we need to cover. One is the importance of a baseline ultrasound. How do you track the follicle? Assessing the endometrium. Finding that exact timing that you should trigger. Make sure that you don't put the patient to any kind of complications, and henceforth. So first of all, what kind of ultrasound is ideal? See, if you ask me, for all sense, transvaginal ultrasound becomes the most important element for monitoring your follicular study, but there are certain circumstances, sexual dysfunctions, vaginismus patients and all, sometimes we might need to end up doing a abdominal ultrasound. But for all practical reasons, transvaginal ultrasound becomes the most important aspect. Whenever we prepare a patient for a transvaginal ultrasound, I think it's very important that we talk to the patient, understand the patient, give them enough privacy, dignity, and then do this procedure. Because unlike other ultrasounds, this is probably more like a vaginal examination. So the patient is in a very compromising position. So it's important that we make sure that we do this procedure with utmost care and gentleness. Make sure you take the patient's assistance. Say they talk about using patient control while you're actually putting your ultrasound probe inside, because you're telling them that, okay, I'm going to insert the probe. Is it hurting for you? So I think each of these steps become a very integral part, because a technically perfect scan still can be a poor scan if the patient comfort is ignored. Then you need to have once you have the probe inside the patient, you need to have a systemic approach of what you're actually going to look at. We're basically looking at the uterus, we're looking at the endometrium, we're looking at the ovaries and the pouch of Douglas. And we do that in a pattern, and henceforth we start identifying certain aspects of these patients' findings. Primarily, a lot of one thing that people ignore, or a lot of times ignore, is the baseline ultrasound, where you basically look at the ovaries, or probably I would say a baseline ultrasound is the best point of time where we can actually evaluate the ovary, unlike any other time of the menstrual cycle. Then you get a better picture of the uterine status, rule out any kind of ovarian pathology. See, for example, this is probably, even if you look at today, your antral follicle count is still at par with the top predictors of your ovarian reserve. So you have AFC, which can be calculated on your day-to-day 3 ultrasound or your baseline ultrasound, which will actually help you in deciding on the dose of your ovulation reduction agents, or deciding on how frequently you need to monitor. You can prevent OHSs in these kind of circumstances. This is probably a place where we can actually differentiate between a endometrioma, you have your irregular corpus luteal cyst, a retained cyst, so you can decide and know whether you need to go ahead with the treatment or not. We can identify issues like hydrosulfings and decide on whether we should actually proceed with this treatment. Whether should we start this treatment or not. You have a fibroid that is pushing into the endometrium. So these are things which we can identify and actually decide on whether should we go ahead with this treatment, and if you're going ahead with this treatment, what is the outcome that we can expect. Even before starting the treatment, by looking at these findings, we'll be able to give the patient a relative idea of what the success rate of this treatment will be. So, and by doing that, like I said, we will be able to identify patients at risk and definitely at least reduce the possibility of complications or prevent them. Once you start monitoring, once you start giving them induction, is when we will start monitoring the patient. Now, when do we start monitoring a patient on follicular study? See, if you look at the physiology, and by understanding the physiology, you know that the recruitment of your dominant follicles happens post day 8. So most of the situations we start monitoring the follicle. Don't go back and look at the follicle on day 6 and say that, oh, I don't see a follicle growing, so I'll cancel the cycle. Don't be in a hurry to cancel the cycle. I would always preferably tell you to start monitoring an ovulation reduction cycle by day 8, 9, or 10, and then only that's where you end up beginning your follicular monitoring. And depending upon the size that you see at that point of time, you can actually follow up and see whether you call them after every 2 to 3 days, or you call them after 1 or 2 days, depending upon the size of the follicular growth, and monitor them so that we are able to monitor it very closely and understand when the ovulation is about to happen. Now, how to actually measure each follicles specifically is very important, because we need to make sure that your borders of the follicles are very clear. You have to have the calipers placed correctly at the inner layer of the follicular rim. At least take two lines perpendicular to each other and average it out, is going to give you the right measurement. Don't try to go for shortcuts where you have a diagonal measurement. Just take a single measurement of diagonals and things like that, but make sure that you always measure it properly, so that, because even a small measurement can actually give you, because now timing your trigger becomes an integral part. So if you're timing it wrong, or if you're assessing the measurement of the follicle wrong and you're timing the trigger wrong, that can actually give you a poorer outcome. Because now technically we understand that follicles most of the time mature somewhere between 18 to 22 millimeter. If it is lesser than that, you might end up getting a little immature follicles. If it is more than that, there's always a possibility of a post-mature follicles, which can either decrease the outcome. Then coming in, once you have a basic understanding of basic 2D imaging of the ovary and measuring the follicle, we can, wherever there's a possibility or wherever people are exposed to some form of Doppler studies, I think it's important that we can actually bring this in and actually start looking at the patient in a different perspective. We should understand that when you're looking at the Doppler flow, when the Doppler flow is reduced, there is some possibility that the oocyte quality is lesser or the maturity is lesser. Hence, if the Doppler flow is good, then the follicle probably is in a better quality and we'll be able to trigger them better. So the two things that we actually look at is the perifollicular blood flow and as well as the Doppler flow of the perifollicular vessel. See, what we understand is that at least 75% of the follicle should have blood flow, which gives us an interpretation that yes, the follicle inside, the egg inside is mature. Similarly, we look at the peak systolic velocity of the blood flow of these follicular blood flow, and if it is more than 10, it gives us an interpretation that the follicle inside, the egg inside this follicle is mature, because that helps us in deciding whether we need to trigger this patient at that point of time or not. Because if these things are less, we can actually wait for some time and then only trigger the patient. Then if you are beyond your Doppler, if you are still getting more information, you have a 3D ultrasound with you, you are able to actually assess in more depth of your follicle. Then we can actually do a 3D ultrasound of the follicle, understand the follicular volume. And they even say that you can actually look at and see the cumulus inside the follicle. And once you see the cumulus inside the follicle, they say it is ready for a trigger. So that cumulus becomes more evident inside your follicle, which is more seen on your 3D ultrasound. We also have technologies available like the Sono AVC, which has made a lot of follicular monitoring easier. But again, I wouldn't say this is a new technology. I would say that this has been there for the last 15, 17 years. But unfortunately, because of sometimes of using it more efficiently, people are still not doing it. But because there is a lot of additions, deletions that needs to be done, the image clarity has to be clear, and then only we'll get an image. And it's more useful in specifically in IVF stimulation cases where we end up seeing a large number of follicles and we are making sure that all the follicles are measured correctly. Then looking at the endometrium. When you look at the endometrium, now what are the parameters that we look at? Obviously, we look at the thickness of the endometrium, we look at the endometrial pattern, and also look at the cavity, if there is some abnormality inside the cavity, and also the endometrial vascularity, if it is possible. Thickness, again, you make sure that you are seeing the uterus from the cervix to the fundus. You see the endometrium throughout the whole line. Look at the thickest part of the endometrium. For example, in this particular scene, it is the thickest part is here. In this particular uterus, the thickest part is here. So there you take the measurement from the subzonal area to the other end of the subzonal area, and then hence we are able to measure the endometrial thickness, and that is where you actually get the thickness. Even a slight change in your probe pressure can actually vary this. So make sure that when you're measuring it properly, you don't put in too much of pressure, because that can actually change in millimeters. Now, what is the right thickness for your best outcome? Now we even have pregnancies reported from 4 to 5 millimeter to 6 millimeter to even more than 19 to 20 millimeter. But for all practical reasons, we always consider 7 millimeter endometrium to be ideal. Pattern, we always prefer a 3-line pattern, and as the pattern changes into a hazy 3-line to a secretory phase, we know that there's a probable presence of progesterone, a premature ovulation, or even helps us in identifying post ovulation that the endometrium is changed. So what we would prefer a 3-line endometrium while we are doing a follicular study till we give a trigger. Now, I always believe that when you want to look at abnormalities inside the uterus, for example, you want to make sure you differentiate a polyp or a submucosal endometrium. I think probably this phase or a pre-ovulatory phase is probably the best time of assessment of any kind of abnormalities that are inside the uterus. Now, in addition to the regular 2D ultrasound, if you're able to use a uterine artery Doppler and measure the Doppler, again, like the same logic applies. If you're getting a better flow into the uterus, that means the uterus is more receptive and in a better stage of implantation. So if you're looking at a power Doppler and seeing the different zones of blood flow, we understand that when you want to give a trigger, if the blood flow is less, we can actually delay and wait for the blood flow to improve and then give a trigger, so that once ovulation happens, it is the best time for them to also implant. Now, if you, again, like I said, if you even have time and effort to do a 3D ultrasound, we are able to make sure that we are ruling out all the abnormalities of the uterus, like any kind of congenital abnormalities, but also look at the endometrial volume, which is also becomes a predictive modality for timing your or making your outcome better. So now all these parameters can be added together and we are able to come out with some kind of a scenario where we can decide on when should we do the trigger. Now, for all practical reasons, if you understand, most of the people will understand once you see the follicle of 17 to 22 millimeter is ready. Yeah, we know that the patient is ready for trigger. But just don't look at the follicle, but also make sure that you are actually seeing a 3-line, at least 7 millimeter endometrium before we do a trigger. Don't be in a hurry to trigger the patient by just looking at the follicle. Make sure that the endometrium is also 3-line. If you're seeing a lot of times patients when you're triggering like this and still not getting pregnant, probably if you have time and effort that is available with you, then you can actually look at the next step of things. Before you give a trigger, make sure that there is a perifollicular blood flow is more than 75%. You have a peak systolic velocity more than 10. You have an endometrial blood flow is sufficient enough. And when all these parameters are met, then only give a trigger. If you have more time and a 4D ultrasound is still available, you can actually look at the uterine artery Doppler. You can actually look at the endometrial volume assessment and also look at the presence of the cumulus ovorus in your 3D ultrasound. So not necessarily all these parameters need to be met. At least meet the first 2 parameters. If that is not enough, look at the next 2 parameters, and only you're actually able to, especially in these unexplained cases around, will be able to fine tune your follicular monitoring better if you're able to get the maximum information from these scans. So once you understand, once you give a trigger, it is also important that you need to confirm an ovulation that is present. So now how do we confirm it? Obviously, now a lot of times we look at the blood flow around the follicle, the hemorrhagic pattern that is inside, free fluid that is there inside, all those things needs to be evaluated. And once this is done, is giving an information that the patient is ovulated. Now, whether should we do a post-trigger scan? Is it necessary? A lot of people don't do it, but we as a protocol always do it because it gives us a reassuring, because we do understand that sometimes there is always this possibility that trigger does not happen and we might accidentally do an IUI at a wrong timing. So we always make sure that if at all when you're doing an IUI, we always make sure that the follicle is ruptured and then only we do it. It is reassuring for us doctors as well as the patients. There is also scenarios where you end up finding a luteinized unruptured follicles where we are not sure if the ovulation has actually happened. But for all practical sense, if you're actually doing a proper follicular study, following up, doing a post follicular scan, post rupture scan, the incidence of this seems to be extremely low. So, and if you're finding this persistently happening, you can alter your trigger and other modalities in the following cycle. Definitely, there are situations where we might have to cancel. Obviously, when you are suspecting a hyper stimulation, where you end up seeing a much higher number of follicles, because sometimes much number of follicles does not always necessarily mean better pregnancy rate, but also a higher complication rate because of multiple gestation. So, if you look at it now as a take-home message, I think it's very important when you're doing a follicular study. It's very important you start with the baseline scan, at least measure 2 parameters. Make sure that your endometrium is also reached to a point where we can see a trigger. Use your Doppler when you feel that your regular scans are still not giving you results. Make sure you understand in which patients we need to cancel the cycle. Ideally, please do an ultrasound post-trigger to make sure that the ovulation has happened. And whenever possible, add all these additional parameters like your Doppler, 3D ultrasound, and make sure that we try and give everything possible to the patient to make sure that the follicular study, whatever we are doing, is giving you the best outcome that is available. Thank you so much for your patient hearing.
Thank you, Parshu, and lovely and welcome to the ICOG platform. We will keep inviting you again and again, and we look forward to your contribution. Brilliant slides and excellently covered in the short time that you had.
Thank you so much.
Very, very useful, Dr. Parshura. Okay.
Thank you, madam.
Yeah.
Sorry, I had to rush
Dr.
in. There's a lot of things, but I think I had to rush in a couple of
No, it was good. No, I
Can
think
I
it was
request
brilliant. And,
Dr. Meeta to introduce our next speaker?
Ma'am, I think Dr. Suresh sir, we are not seeing him. Suresh sir, are you here?
Not joined yet, ma'am.
I think sir is not yet joined, ma'am. If you don't mind, please let's start with Dr. Sridevi first. She's kindly agreed to take the next talk. I'm just trying to get in touch with sir. Meeta ma'am, can you please introduce Dr. Sridevi? Ma'am, unmute yourself.
Yeah, now I was.
Center request. Yeah.
So thank you. Very good evening. Thank you, Chinmay, for inviting me here today. It's a pleasant to be a little away from menopause and be in this little different world. And I enjoy gynec ultrasound, and I think the presentation was crisp and very good. So we look forward to this next presentation. May I have the CV slide so I can just, go through it? I wouldn't be able to.
But I think, Meeta, you are into everything.
Thanks. So we have the Mullerian. Yeah, sorry. We have the Mullerian anomalies. So this is going to be a very interesting talk and a very practical one for people who are doing gynec ultrasound. And we look forward to it. Dr. Sridevi, the platform is yours. Please go ahead.
Yeah.
Yeah.
Very good evening to everyone. I would like to thank the ICOG for giving me this opportunity. Can you hear me?
Yes, ma'am, we can hear you. Can you go full screen, please?
Full screen, please.
Yeah. Yes?
No,
yeah. Okay. Okay. Good.
So everybody is fortunate they got one, and Chinmay gave me two topics in 15 minutes. So let me see how I can do best of this time. So congenital uterine anomalies are the deviation from normal anatomy resulting from the embryological maldevelopment. The prevalence is 4 to 7%, and it's a most common benign condition when we do scans. So here we see there are two Mullerian ducts which are fused, and then the resorption happens, and ultimately leading to the formation of the single uterine cavity, cervix, and the vagina. So why are these very important? Because these are associated with infertility, recurrent pregnancy loss, preterm labor, AUB. But the incidence of preterm is quite high compared to the other things, and it is highest in uterine didelphys, followed by unicornuate uterus, bicornuate, and the septate uterus. The many classification systems, that's the 9 classification systems we can see here. The AFS is very simple, but it doesn't cover everything. So each classification has got its advantages and limitations. But whenever we report, because we use specific classification sometimes, we have to mention in the report which classification system we are using. So what is the ideal time? It is a pre-pregnancy secretory phase, because endometrium gives us the outline of the cavity shapes. 2D is helpful for screening, but 3-dimensional ultrasound helps us to open these cavities and come to the diagnosis. HSG, hysteroscopy, laparoscopy, and MRI are the other modalities we use, and sometimes we use a combination of these modalities. So Escherichia classification, the advantage is along with the uterus, we have the classification for the cervix and vagina. So what is that in the 2D which helps us to think this is not normal? It's a transverse view. So when we can see here in the upper uterine cavity, there is playing of this endometrial cavity. Can you see my pointer? On either side like this. So if you see, like, this is the place where we put the calipers for the axial view or the width of the uterus. But if you see a single one with a beak-like projection or 2 endometrial islands with an intervening myometrium, we suspect there is something which is related to the uterine malformations. And when we open these cavities, this is very simple because it's an unicornuate. But here we see 2 endometrial cavities with an intervening myometrium, but we need to classify in which classification this falls. So we need to know some measurements, and then which helps us put these uterus into different modalities. So before moving to what is abnormal, let us know what is normal. There are 2 things we see in the uterus when we do a 3-dimensional scan. One is the external fundal contour, which is straight or concave. The uterine cavity contour, it's an hysteroscopic view, so it should be either flat or concave, which we call it as a normal uterus. So once we have seen some indentation on the fundal uterine aspect, then we make three lines. The first line is the intercorneal line between the two corneal areas. And then the other one is at the serosal aspect of the fundus. And third one is the deepest indentation. So the intercorneal line is the line where two highest points of the endometrial cavity on either side. But sometimes we see this part of the tube which is going inside this myometrium is there. We should not put it there because that's a part of the fallopian tube. It is not the part of the endometrial cavity. So the internal indentation depth from here, the perpendicular line is drawn to the apex of the fundal indentation. In this picture, we can see here, so how we have to put the correct calipers, and we should not put where we can see the tubes. This is not the correct way of measuring it. We all know arcuate uterus is now as a part of normal variant, but now we have to first figure out whether it is arcuate or not. Here, fundal serosal contour is normal, but when you see the internal indentation, we have to draw a perpendicular line from the interosteal. If this is more or less than 10 millimeters, and the angle between the cavities is more than 90, then we call arcuate uterus. We have seen how we have to measure the internal indentation depth, but how do we have to measure the internal indentation angle? The first point we have to put is at the apex of the indentation. Then 5 millimeters on either side, we have to draw a line along with the endomyometrial interface. That's very, very important, and the angle is taken. So here a green line shows how we have to draw a line on either side 5 millimeters along the endomyometrial interface. But here what happens, see the red line shows that it is an imaginary line drawn from the apex through the myometrium or through the cavity. So this is the correct way of measuring this, because the measurements are the ones which helps us to differentiate from one abnormality to the other abnormality. So moving to the U1, T-shaped uterus is a narrow cavity with a thickened lateral walls. We used to think it's just because of DES related, but now we are seeing more and more non-DES related. Primarily, it can be congenital, but it can be because of the uterine adhesions, tuberculosis, or adenomyosis. So the three criteria, one is the lateral indentation angle, which is less than or equal to 130. Lateral indentation depth, which is more than or equal to 7 millimeters, and T angle less than or equal to 40. If all the three criteria are present, we call it as T-shaped. If there are two, we call it as borderline. If there is one criteria, we call it as normal. And this is how we measure the indentation angle, depth, and the T angle. So many times there is a confusion between the T-shaped uterus and infantile uterus. Is the ratio of the uterus and the cervix is 2:1 in the T-shape, but it is 1:2. The cavities are narrow in both, but the lateral wall thickness is more in T-shaped uterus, but it is normal in the infantile uterus. So here we can see the T-shaped uterus. But sometimes what happens, there might be the endometrial pathologies which may cause the distortion of the uterine cavity. Here is the limitation. We cannot diagnose the T-shaped uterus. So moving to the septate uterus, which is U2, it is very simple. Again, here, if we get a proper coronal view of the uterus, first, as I have showed, the first line is the interosteal distance. A perpendicular line to the fundal serosa, if it is more than 5 millimeters, that means the problems of the fusion is not there. So then the second line is drawn from here to the deepest point. If it is more than 10 millimeters, we call it as septate uterus. And if this septum is up to this internal os, we call it as complete. If this is beyond that or like short of that, we call it as subseptate uterus. So how do we measure the length of the septum? It's till the deepest point, and the residual cavity is from the deepest point to the internal os, gives the length of the cavity. Sometimes we have problems or confusion with the diagnosis of bicorporeal versus septate uterus. This fundal line helps us because if this fundal indentation is below the intercorneal line or less than 5 millimeters, it is bicorporeal. And if it is more than 5 millimeters, that is septate uterus. The basic concept we need to remember is bicorporeal is a fusion problem, septate is a resorption problem. So the bicorporeal uterus, we can see it that actually there are two horns which are wide apart. It is very difficult to get both in the same thing. Each have its own cervix, and when we do 3D, each of it will have a cavity which is similar to the unicornuate uterus. So moving to U4, hemiuterus, usually these uteruses are not in the midline. You can see here it is abruptly, this one corner is seen, but the other side it is not seen, beak shape. And when we open the cavity, we can see a banana shaped cavity. So here in this video, we can see how it is not in the midline, but deviating to one side, this horn. But we should not stop at this point, but we should look for any horns are there. We can see there is a horn here. And this horn is, this is a right unicornuate uterus with the left horn, and there is no endometrial strip. It's very, very important to see for the horn whenever we see a unicornuate uterus, and we also have to look at the kidneys of the patient. So moving from the uterine anomalies, we have to always look at the cervix. This is the case where I put some gel in the vagina, which we are able to see a normal cervix. And this is a case where we can see the normal uterus, but there is no cervix. There is a small cystic lesion in the vagina. This is post-surgery. She is able to menstruate. So we can see here a single complete septate uterus with the single cervix, or there is two cervix. So gel vaginal sonogram, where we put 20 cc of gel in the vagina, helps us to see these external os and these cavities so well. This is septate uterus. We have a double cervix and the transverse vaginal septum. So this picture we can see in the top row, it is two horns which are wide apart, and there is no intervening myometrium at all. There is intervening myometrium, but we can see indentation here itself. And here the myometrium is fused, but still these endometrial cavities are far apart. And here the endometrial cavities are closer compared to the previous picture. So this is a spectrum from the non-fusion to the resorption. So three types of uterine anomalies we always come across: agenesis or hypoplasia, which comes under unicornuate uterus, or the fusion abnormalities or bicornuate and didelphus, and resorption abnormalities most commonly are the septate and arcuate varieties. We have 9 classification systems, but the current knowledge which we have is all based on the AFS classification and Salim classification. New classification systems are yes, but we don't have the proper papers on how the treatment modalities and how the outcomes. Most of these are from this AFS classification. So whenever we are giving reporting on the new classification systems, we have to draw a picture and write which classification system we are using. So to conclude, 2D ultrasound is a screening procedure. Unless you know when to put a 3D or when to refer a case for the 3-dimensional ultrasound or an MRI, we'll be missing these cases. So 3D ultrasound is one modality in gynec in uterine anomalies, helps us to come up with the diagnosis. Sometimes when you use most of the modalities, like, when we use 2D, 3D, sometimes we put gel, sometimes we use MRI, laparoscopy, hysteroscopy, but we may not come up to an accurate classification, which might happen in 10% of the cases. The reason being is it's a spectrum of presentation. We don't know when the embryology stopped. So we may not see same kind of uterine anomalies in the different patients. It might be a combination of the things. So this picture shows like how we all look different. These are all the normal uterus, but none of them look same. So do not treat the image, because many of the times, though the women have a uterine anomaly, they might have a normal pregnancy, everything might be normal, and they might come for a regular checkup, and you see a uterine anomaly at around 30 or 40 years of age. Don't jump and say, I want to treat this. So symptomatic patients who needs treatment, they only should be subjected to treatment. Thank you. And moving to the tubal evaluation, I'm just going to make it very short. Tubal evaluation we used to do by Sion procedure, saline infusion, saline salpingography. So where only saline is used, or air or Doppler, or contrast saline sonography or histofoam saline sonography are used. Most of the time we use the number 8 Foley's catheter with the guide wire, and I personally use most of the times IOI catheter. And we use the balloon, we distend the balloon using 1.5 to 2 ml of fluid. The first picture you can see, this is a trans-abdominal scan, because I do procedures along with my colleague. So and we always do somehow, the first cases we used to initially do with the empty bladder, but what we realized is partially full bladders are helping us with with acute flexions or retroflexion or anti-flexions. So here you can see how the catheter is passed. Once they do this, they remove the speculum and then we go transvaginally. See, and the first thing we put is saline into the cavity and see the cavity, any problems in the cavity are there. We just put 2 to 3 ml of normal saline into the cavity. After we do this, this actually helps us to pick up smaller problems in the cavity. Like here you can see there's a small polyp in the upper uterine body, which we might miss it when we do the scans. So once we do that, we use 5 cc of xylocaine gel, and we mix it with normal saline. We agitate it, like it will become like a foam. So once we do it, we nicely foam it. What we do is we take out the first syringe which has saline, and we connect this syringe to the IUI catheter or the Foley's catheter, and then we inject the agitated solution, which is basically foam air. See, once we put it, it shows us as this hyperechoic area, and you can see nicely the interstitial part of the tube, and you can see the tube like this up to here. And then we can see on the left side, you can see the tube nicely. We can see the ovary. You can see the spillage of the fluid. So in the same sitting, we do saline and followed by the foam. So it is usually used for patients with short-term infertility or patients who had no previous surgical interventions, or in patients who already had laparoscopy before, but the tubal status is still in doubt. FOGSI is recommended by NICE as an investigation of choice for otherwise asymptomatic women who need fallopian tube assessment as part of assessment of the fertility. But we have to remember this is a screening test. In this test, if we see the tubes are not patent, we always have to tell the patient that this is not a diagnostic test. We have to confirm it by the laparoscopy. Thank you. Thank you for the patient hearing.
Thank you, Sridevi. I think, tackling two complex subjects, you've done a wonderful job. And the take-home message for the first talk is, don't interfere unless the woman is symptomatic, the most important message there. And the second one, I think your video demonstration is probably very inspiring for the youngsters who have logged in today to really do it the way. So you have demonstrated actually, and that's what a class means. That means you're not just talking, but you're showing how to do it. I think that really impressed me. So two very good take-home points from your thing today. And of course, to understand the first part and to really put it in practice, the first part of your talk takes a little while. So everybody has to work hard on that. Thank you, Sridevi. So if anybody
Thank you
else
so
wants to
much.
comment on this or any questions. So I have a question, Sridevi, for you. So when you have this double cervix and septum, which is going right down to the external os. So sometimes it gets very difficult to understand whether that's a complete septum going down right up to the cervix when there is nothing in the vagina. There are two different cervix, or it's a septum which is going down. So some cases, where you have this complex
Yes.
anomalies.
Madam, the first thing is the suspicion, whether it is two cervix, it's a septum is there. So I didn't put the picture here, but when we do the scan, vaginal scans, we have to eyeing it from the time we put the probe from the internal, from the introitus.
Yeah,
So we can see a bright line which is actually moving on your probe. That means that there is one more layer between your vaginal wall and your probe. In those situations, what I do is I have shown in few of my pictures, which I regularly use, is I take 20 cc syringe and I actually pull out the plunger. We fill the thing with the scan jelly.
Yes.
And then what I do is one finger PV and then put the gel into one side, and then I put my finger with the finger guidance. I put some more gel into the other one. So this gel in the vagina helps us to say till what extent it is a longitudinal septum or it is a transverse septum, oblique septum. And it also helps us to see the size of the cervix, because many times what happens when they do hysteroscopy, when they use the speculums, one side, if it is small or a transverse septum, they might miss that part. So this helps us to give those exact length and the thickness of both the sides, and to the extent also. And if in very rare cases, if I still can't, because it's a vaginal thing, I put gel and I do transrectal scan.
Transrectal scan. Yeah, I was actually, this is talking about the transverse septum, but I don't know whether we have the time, Chinmay.
No, we have the time for discussion, ma'am. We are just waiting for Dr. Suresh to join. Yes.
Okay. So maybe any other questions? But my question was actually about not the transverse septum. I was talking about the longitudinal septum.
Yeah, longitudinal septum.
Yeah, the two, because that becomes very, very important for your management.
Longitudinal septums is the single finger guided. I put gel in on both the sides.
Correct.
So that gives us the length.
Inject the gel. Do you inject the gel or you just leave it in the thing?
No, it is not injection. It is like, 20 cc syringe, you have to fill it.
In the vagina.
The back side of the plunger you have to take. The scan gel you have to fill in the 20 cc syringe.
Yes.
And just you have to do this so that there is no air bubble in that. So once there are no air bubbles and you put it, the whole vagina is like, is full of gel.
Gel.
So the moment
you put it in what? The posterior fornix or anterior fornix?
It's in the vagina.
Like an acoustic window, that's what
it
she's
is
trying to say.
everywhere. 20 cc is anterior, posterior. The whole of the vagina will be full of that gel.
So you're doing this to enhance the contrast between the cervix and the...
So the syringe goes almost up to the posterior fornix, and when I'm putting it, I'll be withdrawing it. So I don't want any air bubbles in any part of the vagina. So I'll be filling it and I'll be withdrawing it. So the whole vagina is with the 20 cc thing. If I can share, I think I can share one of that video also. Because gel vaginal, it is just not for the septums, ma'am. It is very useful for the polyps and to see the pedicles, vaginal cysts, whether it is
obese women.
Not obese women. Whether it is just a vaginal cyst or a Gartner's or something, or sometimes when we see for the DIE nodules, when I'm not able to see, I put gel and I do transrectal again. So what happens is I have a good vagina with the gel anteriorly when I'm going, because sometimes the rectovaginal septum, I can't see it well.
Yes.
But when the symptoms are typical and the pain is typical there, then I move, because transrectal is what we have in the mind. It is not that difficult. It's very simple. So we just use local xylocaine jelly and then we just put that into the rectum. So this contrast helps us to see the rectovaginal septum better.
So I have one question for you, Sridevi. When they're widely separated, the horns of the uteri, that time getting a picture either by trans-abdominal or by transvaginal, getting that whole the uterus in one picture, what is the trick for that?
Depth.
Yeah. So
you have
which is the best? Which is your best plane for acquisition?
Transverse view. For any of the uterine anomalies, it is transverse view.
So that you can see both the edges, yeah.
Your depth has to come down. So your image becomes small. And when your depth comes, see, there are two aspects you're looking. One is fundal serosa. The second one is the cavitary aspect, which you're going to see it in the fundal and the upper uterine body. Because once you're beyond the 10 millimeters in the cavity, you know what you're looking. So once you're seeing there is no fusion, you know you see. So transverse view of the uterus, where you have to decrease the depth and put your ROI box large, that either side it goes, and then use the maximum angle. So normally we put 60, 90, but whatever maximum angle on your mesh, you increase that angle. So it acquires the thing. So if your thing has a problem even in the mid and lower uterine body, the second acquisition has to happen from the mid uterine body to the cervix with gel inside.
Yeah.
So the two acquisitions we do. We don't do a single acquisition if the full thing is there. The single acquisition I do only when I'm confirmed with my diagnosis. I think for presentations I do a single.
I see Dr. Suresh sir has logged in.
Yeah.
I have sent him a unmute request. Can I request sir to please go ahead?
Thank you, Sridevi. Thank you.
Thank you, ma'am.
Thank you
and
for
thank you for giving me this opportunity.
Thank you, ma'am. Fantastic videos, lovely presentation, and you cleared everyone's concept so beautifully.
Thank you, sir.
Dr. Uma, are you here? Dr. Uma Pandey?
I think she was logged in from the mobile. If she's not there, then Dr. Chinmay, you can go ahead.
So it's a real pleasure and honor to introduce Professor Suresh, who's the doyen of Ob-Gyn ultrasound in India, the father of fetal medicine in India, actually. And Sir is the director of the Mediscan Systems, Chennai, and the honorary secretary and voluntary CEO of the Health Services in Chennai, visiting professor in perinatology, SRMC Chennai, and PhD Hospital, Coimbatore, and adjunct faculty in IIT Madras, and he is part of some amazing projects which are going to show some amazing results in the years to come. Sir has been a teacher of teachers, and he has really set things in a standard that, you know, all of us have learned from whatever he has given us in terms of tutorials and lectures, and a lot of pearls of wisdom in all these lectures that we have heard from him. Today, he will be talking about interventions in obstetrics and gynecology. And as we all know, he has a really packed schedule, and we kind of pulled him out of something very important that he was doing. And sir, thank you so much for joining us. And we are all eagerly waiting to hear from you in this ICOG Masterclass.
At the ICOG convocation in Bangalore, Dr. Sheila Mane ma'am and I, along with the rest of the ICOG team, will be privileged to present the honorary FICOG to Dr. Suresh. Been passed in the last governing council meeting, and we look forward to honoring sir and felicitating him in person.
Thank you. Thank you very much.
Sir, for accepting. I know your busy schedule may have pulled you out.
Yeah, thank you. Just a quick question. I understand from that it's diagnostic interventions I'm going to talk about.
Yes, sir.
Okay. So this is a quick, very quick overview.
Also includes embryo reduction, sir.
Yeah. So the quick overview of diagnostic interventions in fetal medicine. Basically, we know that when we want to practice fetal medicine, it's not a single person's job. there are several people involved. There's a big ecosystem that is involved, and that ecosystem is actually expanding also. So we definitely need to have the fetal medicine specialist, the primary obstetrician who's treating the managing the pregnancy. Then we have the geneticist, we have the perinatal pathologist, we also have the neonatologist and subspecialist who all come into the picture at any given point of time as per the need. Now, when we talk about diagnostic interventions, let us first look at a few clinical scenarios. Here's a 26-year-old G3P1LO, first child died at birth, cause not known, was told to have a cardiac defect. Now, to her, what we do is we do a targeted scan in the first and second trimester, and we do intervention only if it is required. Because they said cause was not known, next time there is no going and doing an intervention without knowing what is the problem. Now, second is a 32-year-old gravid of 4P1A2, previous 2 pregnancies, high drops, cause not known. So we know it is high drops. We also know it is non-immune high drops because she is Rh positive. And in such cases, what we do targeted scan in first and second trimester. We can do some degree of pre-pregnancy workup. We can gather details of prior loss. And if there is any data available either by autopsy or anything like that, we know which direction, whether the baby is having a hematological disorder or having a metabolic disorder, which caused the high drops. Now, in the absence of that, our hands are very tied. We just need to do the routine screening and like what we do for everybody else. And at the earliest sign of high drops, we start investigating. But here's a 25-year-old with both partners carrier for thalassemia. It's not an uncommon scenario in India. Now, if there are some parents whom the mutation has already been identified, then we can plan very early prenatal diagnosis. In fact, they get a pre-pregnancy counseling that invasive procedure has to be done quite early. Now, if the parents have not been investigated and you first identify because the mother has got anemia, then you find out that they're there, then in non-identified mutation, in a country like India where the most common mutations in thalassemia are known, then we may want to investigate all 3 at the same time. But again, that is it's fraught with a little bit of danger. So we might want to quickly send the parents for mutation, and then once you identify the mutation, do a testing for the baby. Now, 23-year-old Rh negative, isoimmunized with fetal anemia. Now, this case, we have to plan fetal treatment. Now, would I go and do invasive procedure and do a fetal blood sampling prospectively? That's what we used to do many years ago before the advent of MCA Doppler. Because MCA Doppler is now available, we plan invasive procedure only when we know that the baby has crossed the line of the MCA being double the gestational age. So fetal interventions can broadly be divided into diagnostic and therapeutic. CVS amniocentesis, fetal blood sampling. Fetal urine sampling is not I'm going to talk about, but I'll mention it a little bit. And therapeutic procedures, of course, we are not going to discuss today. Now, what are the indications for diagnostic procedures? The most common is a positive screening test. Second is anomaly detected on ultrasound for the first time. And fetal infection, suspected fetal infection, inherited disorders, parental translocations which have already been identified, prior baby with a chromosomal abnormality. Most parents with the first baby having Down syndrome would opt for a direct testing rather than go for a screening in this pregnancy. Unexplained fetal growth restriction, especially very early onset growth restriction, advanced maternal age, and couple's choice. Because there are some couples who come and tell me, I want 100% guarantee that my baby does not have a Down syndrome. The risk as per the screening test is 1 in 2,500. They say we don't want to be that 1 in the 2,500. Do a testing. And we have had some cases where the risk was 1 in 7,000. And ultimately, the baby turned out to be Down syndrome because of parents' insistence we do that. So we always throw it open to the parents. and it's their choice for identifying this condition. Now, before we do a procedure, there is a pre-procedure counseling. The reason for offering the invasive procedure, the technique of the procedure-related risks, the limitations of the test, post-procedure instructions, limitations after a normal and abnormal, implications after a normal and abnormal result, whether sample is being stored or no. And of course, we need to do PCP compliance. Now, which test to do and when? Chorion villus sampling, which is the earliest test which is done, we can do karyotyping for numerical aberrations. And if there are translocations, then we prefer not to do chorion villus sampling, but rather go for amniocentesis. Molecular testing, any condition which requires DNA to be tested, like microarray or whole exome sequencing, then CVS is very good because you get a good amount of DNA material. And whole exome, whole genome, all these tests would require a good chunk of DNA, which can be just extracted from that. Now, amniocentesis, when you're looking at numerical chromosomal abnormalities, often when a screen positive test happens only because of biochemical risk, when the NT is normal and the biochemical risk puts you there, a simple Q of PCR and a karyotype will do the trick. You can still do a CVS, but in case that there has been a delay in the screening process, then we can do an amniocentesis. Supposing you finish the screening process at about 14.5 weeks or 15 weeks, then we'd rather wait for 1 more week and do the amnio rather than do a CVS at that point. So numerical, structural abnormalities, structural chromosomal abnormalities are better done on the amnio. High resolution banding gives you a much better result. And all these, of course, are moving towards molecular, like microarray and exome sequencing. Infection and PCR, it's very good because if you're looking for fetal infection, then sending an amniocentesis for PCR for CMV or toxoplasmosis or parvovirus, for example, can all be done. Now, fetal procedure, all of the above tests can be done. Plus, additionally, we get direct access to the fetal circulation where we can do fetal blood sampling. The most important thing is we need to do the right procedure for the right patient and the right operator doing the procedure. So let me talk about chorion villus sampling here. Usually done after 10 weeks. The transabdominal approach is most common. We used to do many years ago transcervical approach, and we have sort of given that up in the last maybe about 15 to 18 years because transabdominal is so much more easier to perform. But there are still centers who perform transcervical CVS, which is perfectly all right as long as it is safely done in their hands. Now, local anesthesia is necessary. We do an 18-gauge needle. That's why local anesthesia is necessary here. We try to get the placenta as vertical as possible, and then you can get a few passes which you put together. We generally try to heparinize the needle before putting in and add a little bit of media into the syringe, and the material is sucked into the media. But what is most important is to know about the tissue quantity and also how the tissue looks like. When you look at the chorionic villi, they should be white in color and they should have small branching villi. The branching villi are very important. Those are the ones which will be cultured and will be seen. Because what can happen is if you are very, very close, for example, here, if the needle is very close to the placental attachment to the uterus, the base of the placenta, then they can have maternal contamination. All prenatal testing for once you take a sample, they will look for maternal cell contamination before reporting on the genetic results. The advantages of CVS are the DNA quantity is better, the earlier procedure and earlier result. And you can see that this is a visual impression of 10 milligram, 20 milligram, and 40 milligram. This is an inadequate sample. and these are blood-stained samples. Blood-stained samples can be there as long as they're able to see white villi, and these villi will be teased out in the laboratory. The issues are placental mosaic, which is rare, translocations, amniotic fluid is better, as I said, and procedure-related risk is about 0.2%. Now we move to amniocentesis, which is done after 15 weeks. Here we use a 22 gauge spinal needle. No local anesthesia is required, and about 15 to 20 ml. And if you're doing molecular testing, you probably require a little bit more. And so when we do the amniocentesis, we try to avoid the placenta, but in the case of strict anterior placenta, there is no harm in going through the placenta. We can quickly go through and get it as long as a placental vessel is not punctured. Now, once you remove the amniotic fluid, it's important to see the quality of the amniotic fluid. Clear fluid is what we expect, but sometimes there can be blood stain. The issue with blood-stained amniotic fluid is, especially if you have gone through the placenta, we do not know whether some maternal blood has gone and mixed there, and the results can be a little bit troublesome. Sometimes we can get very brown-colored amniotic fluid. This brown-colored amniotic fluid actually means that the mother invariably has had bleeding in early pregnancy, or someone has done a procedure before, unsuccessful procedure, there has been some bleeding into the amniotic fluid. Invariably, almost all patients whom we have asked, when we see a brownish colored amniotic fluid, they have had a significant bleeding in early pregnancy. Now, whether this is suitable for culture or no, it's only the lab can tell, depending on the number of amniocytes that they get. So we can use amniocentesis for rapid aneuploidy testing, FISH, QF-PCR, bags on beads. We don't do that anymore now. Instead of that, we use CN genome, PCR, infection, biochemistry. We can do biochemistry, like, for example, congenital adrenal hyperplasia. If you don't have the mutation, we can do some biochemical analysis. Bartter syndrome can also be identified. We can extract DNA and store it. The amniotic sites are cultured, DNA is stored after extraction, and molecular diagnosis. The only disadvantage here is the long waiting period. We need to wait at least about 2 weeks to get the results. Now, fetal blood sampling is done usually after 18 weeks, because before 18 weeks, the umbilical cord is very thin, and even if you want to go to the intrahepatic portal vein, it's very thin. Now, once you crossed 18 weeks, here we can use a 22 gauge needle, but if you are going to perform an intrauterine transfusion in addition, then we need to do a 20 gauge needle. So a 22 gauge needle, we don't need to give local anesthesia. We can go to the base of the cord. This is the attachment of the cord. We can go through that. Sometimes the cord is very when the attachment is so clear that you can actually through the base of the cord without puncturing the vessel. Now, once you go, you must be careful not to counter puncture the vessel. Then once you're there, you take a sample out. Now, because we have gone through the placenta here, it's always important whenever we do fetal blood sampling, irrespective of how we have gone through there, the first few milliliters must be discarded. Similarly, in amniocentesis, the first few milliliters are discarded. So once you discard this, the next is take the blood sampling. Important to know what all samples to collect, but depending on what you want to do, depending on what you would like to do, the sample has to be collected in either heparinized tube or a EDTA tube, because for DNA you need EDTA, and for karyotype you need a heparinized tube. Then we can also do fetal blood sampling through the intrahepatic route if you don't have a proper access there. Can also be done in the free loop of the cord, but the intrahepatic route is something which is a little better than the free loop of the cord. Now, I'll show you the free loop of the cord, what happens when you do. Here's the free loop of the cord, and I'm going to do a fetal blood sampling there. And because there's nothing to support the cord will keep moving away. So you need to go do a significant jab to enter the cord. And once you take the sample and you try to remove the needle, then there will be a hole which is created in the umbilical cord, where now it says, you can see I've overshot it and then brought it back. And then once I finish this, you can see the blood oozing from the cord. So once the blood is oozing, you don't need to worry because it within about a minute or two, it will get stopped by itself, but not something which we would like. Now, lastly, when there is a fetus with a significant anomaly where they're going for termination of pregnancy and it's early in pregnancy, you can do a direct cardiac sampling. So here I'm putting the needle into the fetal heart and doing an intracardiac sampling, which makes the things much easier because we are not going to be worried about the cardiac heart stopping because of the procedure. But in 9 cases out of 10, the heart really does not stop. You can get a bradycardia, but the moment you pull out the needle, the heart rate will pick up again. Right. Then a word about twin diagnostic procedures. When you have a dichorionic twin or a monochorionic twin, in dichorionic twin, the fetus are to be tested individually because rarely there is genetic concordance. So here is a CVS which we are doing on a dichorionic twin. That's the dividing membrane. I'm going on one side, then I do the other side, make sure that I'm not cross-contaminating with the other placenta. When I'm doing amniocentesis, then I try to have the membrane in sight, so that I'm going on one side doing the amnio, then on the other side. Many people have said many techniques for this, injecting a little bit of dye inside and all that, but that's not necessary as long as you're clear where the membrane is. Another thing is you can actually keep that needle in for a while we put the other needle and make sure they are on the opposite sides. Of course, there are slightly increased procedure-related risks. So post-procedure instruction, these are the things patient have a pre-procedure. We don't give any pre-medication. We don't give any anesthesia. We don't give any antibiotics for just a routine procedure. So can I travel? Can I have a bath? Can I climb stairs? Can I have a normal diet? The answer is yes to all of them. And when can I return to work and exercise? Usually a day after. What are the red flag signs if I need to seek help? Excessive pain and cramps, bleeding, leaking fluid, pervjanum or fever. When can I expect the results? The turnaround time for fish is about 3 to 5 days, or QFPCR is about 3 to 5 days. Karyotype is 2 to 3 weeks. Genetic testing depending on the test and lab. Complications: amniotic fluid leakage, chorioamnionitis, and miscarriage. The loss rate for amnio is 0.11%, and the CVS is 0.22%, and fetal blood sampling is about 1%. Okay. The concerns are in CVS, if you do a karyotype, placental mosaicism, and maternal contamination, amniocentesis, culture failures can happen, and a bloody tap, which I told you, and microarray and sequencing, you have variation of unknown significance which can there. And the essential role of the geneticist comes here at this point. Lastly, I'll complete my talk with multi-fetal pregnancy reduction. Now, the question of higher order gestation, starting with triplets. There's always been a controversy whether triplets should be reduced or no, varying thing, but the evidence has shown that reducing triplets has reduced to twins, has reduced GDM by 70%, reduced preeclampsia by 60%, less likely to be delivered before 32 or 28 weeks, higher birth weight at delivery with a mean difference of 500 grams, less need for prenatal hospitalization, and mean difference almost 12 days, and less neonatal death rate. So there is justification for reducing triplets to twins, but it's a parental choice which we do. Now, when you have TCT triplets, one of the things is to find out which of the fetus to reduce. Now, when you have fetuses distributed like this, we call this as A, B, and C, and we look at all the CRLs, the good anatomical evaluation. That's why we do not do very early reductions. We wait till about 11 to 12 weeks to get a reasonably good anatomy of the fetus and the CRL. The fetus with the smallest CRL, the fetus which shows any signs of abnormality or any difference, which is marker, which I feel will develop. is the one which we'll choose. If all are equal, then we try to choose the fetus at the topmost or near the fundus. So you can have TCTA, and you can also have, you can see a dichorionic triamniotic triplet. So you have a monochorionic pair and a singleton here separately. In such cases, we always try to do counsel the couple for reduction of the monochorionic pair because of the 15% chance of complications of monochorionic twins which can occur later. Of course, there are some couples who have insisted that they will continue the monochorionic pair, and we do the singleton. So the important thing here is counseling will play a very, very major role, and it is the parental choice which we have to do. Just once again, sorry about this. Something happened here. Yes. Right. So choosing the right fetus is important. So in the pre-procedure evaluation, you see a structural anomaly, it's very, very easy. And the DCTA triplet, I told you the MCDA pair is done. Significant CRL-NT discrepancy, location away from the cervix. But what if the fetus close to the cervix is the smallest one or has an anencephaly? Safely, the procedure can actually be done. Safely, the procedure has been done without any difficulty. Then the accessibility, of course, is very, very important. Let me move it on. Right. So the pre-procedure counseling is risks of the higher order, risks of the procedure loss rate of about 5 to 7%. Allow the patient to choose and allow do the documentation, and we usually give 1 dose of antibiotic prior to needle entry. So here we can see we use a 22 gauge 15 centimeter needle, no anesthesia is given. We use lignocaine for causing asystole, lignocaine into the heart. Before we used to do KCL, of course, KCL is also a thing which can be used. So the needle is coming here, we target the heart, and then with a quick jab, we go intracardiac. Now, supposing you miss the heart and you are in the thorax, it's still all right to give, maybe it requires an extra dose. Usually 1 to 2 ml of KCL, if you're directly in the heart, should be all right. The older the baby, the more the dose that would be required. Now, post-procedure red flag signs could be understood, like pain, bleeding, fever, and all that. Now, there are sometimes you can have some technical challenges where the entry can go, you can't go from the front end of the probe, but you need to go from the back end of the probe, which is there you can see the needle going there. You might need to avoid a vessel or something like that, just there. And another thing is contraction. The moment you put the needle, you can have a heavy contraction at the entry site. You can see the contraction. Once you have the contraction, what happens is the needle is held very tightly by the contraction. And then you'll have to wait for some time before the contraction goes away, before you can achieve what you need to achieve. So this is another issue which is being there. So we have had monochorionic triamniotic triplets. And here the parents have asked for reduction of 1 pair. And this is a nightmare because we can't use KCL, we can't use lignocaine, and we can only do reduction by radiofrequency ablation or microwave ablation of one or the other after 16 weeks. And certainly, of course, the loss rates are higher. So what I will do is, I think I will stop here, and will be happy to answer any questions if there are any. Thank you for the opportunity.
Thank you, sir. Dr. Uma. Dr. Uma Pandey, are you there? You want to wrap up?
I think Dr. Uma Pandey has logged out. She is on call, so she is not able to speak.
Neeta ma'am, are you?
Thank you very much, Professor Suresh. That was fantastic. And I think in just 15-20 minutes, you covered so many different aspects. It was truly a treat for all of us. And I can see that there are 300 people still logged in at the end of the program. And we have exceeded our time by half an hour, which speaks volumes for the excellence in this masterclass.
Yeah.
Thank you, sir. Thank you once again for giving us the time, and we are privileged to have you
Thank
as
you.
a faculty. Yeah, thank you. And
Thank you.
see you soon in Bangalore in
Sure.
August.
Sure.
And
Thank
we
you.
hope you will be more and more on the ICOG platform, sir, now that you are our fellow.
Sure. Sure. Thank you.
Thank you so much, sir.
Bye.
Good evening, sir.
Bye. Bye.
So, bye, sir. So, thank
Excellent
you.
talks from all three speakers of that final session. Can I request the conveners who are present to present the final vote of thanks?
Thank you, Pratik sir, for the opportunity. Sheila ma'am, the chairperson of ICOG, Pratik sir, the secretary of ICOG. It's really been an honor to be in the ICOG Governing Council with all of you. And we have such spirited co-governing council members also, that not only the conveners come together and work like a team, but also all the others, they stay there and root for us, which really makes us feel very nice. And that is something we are always grateful for. So at the outset, I thank ICOG for the platform. Professor Bhaskar Pal, our president, FOGSI, for the permission to do such kind of master classes, and for the entire platform, which makes us, get so many nice delegates who stay with us till the end and encourage it. So my heartfelt thanks on behalf of all the three conveners, Dr. Sita Ramurthy, Dr. Kanchan Prasad, and myself, Dr. Chinmay, to our chief guest, Dr. Meera Agnihotri ma'am, who came and encouraged us there, to all the chairpersons, Dr. Deepa Gupta, Dr. Archana Base, Dr. Anita Rajoria, Dr. Upma Saxena, Dr. Sampath Kumari, Dr. Saijas Nair, Dr. Naren Malhotra, Dr. Meeta Singh, and Dr. Uma Pandey for being part of the program. And of course, all the speakers, Dr. Supriya Sheshadri, Dr. Vandana Bansal, Dr. Bela Bhatt, Dr. Kusha Gradi Ghosh, Dr. Parshu Ram Gopinath, Dr. Suresh, Dr. Sridevi, and myself and Dr. Sita. So, it's been a very hectic 3 hours. We've covered so many topics. In fact, some we had to rush through, some we managed to have some discussion. But the way the audience interacted with us was really amazing. So thank you to the entire audience, who were at one point more than 500, and towards the end also around 300, to boost our morale. So thank you very much. And the ICOG office, Nilima, and the entire team who coordinated the back-end management of this program. So thank you very much. And before we log out, all the ICOG office bearers, Dr. Ashok Kumar, Dr. Sadhana Gupta, for being there and encouraging us. Suvarna ma'am also for being a part of FOGSI. Thank you so much, sir.
Dr. Kanchan, any closing remarks?
I want to thank the ICOG chairperson Sheila Mane ma'am, and of course you, sir, Pratik Tambe sir. You are into you always give such a academic platform. It's so interacting, and audience are really very. You can see so many chats in the chat box. So I am very happy to be part of it. Thank you so much. And all the speakers were excellent and master in their fields. So thank you all the speaker to impart the knowledge and interact with this. Thank you so much. And thank you my co-conveners Chinmay ma'am and Sita ma'am. Thank you ma'am.
Thank you.
So thank you audience
I
for being
just
here. We look
wanted to
forward to
share.
seeing everybody at
I
the
wanted to
conference.
share one comment by one of the members when I met them in UPCon. They said, "Madam, आप students को तो पढ़ा ही रहे हैं ICOG के through, आप हमको भी पढ़ा रहे हैं." मैंने बोला, हम भी सीख रहे हैं.
Learning is a lifelong process.
Yeah, everybody is
And one
learning.
learns best by trying to teach.
Yeah.
That's very true.
So thank you, audience. We look forward to seeing you at the ICOG annual conference, 22nd, 23rd of August. Details are there on the ICOG website. We'll also have the convocation. Those who are not fellows, please apply. 15th of July is the last date, and we look forward to seeing many of you at the annual conference in Bangalore. Until next time, goodbye, God bless, and thank you, everyone.
Thank you. Thank you, sir.